annual retreat. Looks like most of our board members are just logging in. I see Chair Bangsberg's just logging in. So we'll give everyone, and here comes Oscar Arana. We're just going to give everyone a couple more seconds to settle in here and for the board members to turn on their videos if they're able to, and then we'll go ahead and get things started. Okay, Diana, I think that I've seen Ebony and I know John Santa's here. So we have all 6 board members present. So I'll go ahead and kick things over to you for the start of our retreat.
Thanks, everybody. I'm going to first turn it over to Chair Bangsberg, and he's going to open us up, and then we'll hear from Pat Allen, and then I'll do an overview of the next couple of days. So David, please.
Well, thank you, Diana, and so much for organizing this retreat. Look forward to it. Have a few thanks. My first thanks, though, go to PG&E for restoring my power at 10 p.m. last night. Thank you so much, PG&E, because I was not I was really anxious about listening to this on my cell phone. So great to see you all. I'm glad you all have power and can join us today. Special big thanks to the OHA staff for the hard work they did in preparing this, and Diana organizing preliminary meetings, planning meetings with different board members. Thank you all. Big thanks to Oscar Arana, my vice chair, for helping plan the meeting. We've been thinking about this for weeks with Diana and Tara and Jeremy and Trilby's help. So we look forward to a great meeting ahead. I think what we're looking forward to is reviewing our progress as a board, what we've done together, to sort of celebrate that progress, to review it, to go into some detail in terms of the structure of the board and how we work with our committees to do the work progress we've made thus far and the progress we hope to make. And then I think that will be the agenda for today. And then moving forward, we're going to talk about the priorities going forward based on the governor's letter. And I look forward to a discussion on how we trade off breadth versus depth, because obviously we have so much we are working on and thinking about as a state, as a board. And I think we look forward to our deliberations, say, how do we serve the state and the people of the state the best possible. I really look forward to hearing all of your deliberations. One of the great things about being a dean of the School of Public Health is I'm surrounded by great people. I'm always learning, and you all are no exception in terms of I always learn the most from listening to you all, and I look forward to what you will teach me over the next 2 days. So with that, Oscar, do you have any comments you want to add?
No, I just want to thank the OHA staff and leadership and our fellow board members for all their time and dedication to this work and putting together all the documents. And thank you, Diana, for facilitating and leading us through the next couple of days. Thank you.
Great, thank you.
Thank you. Pat, wanted to give you the opportunity to say a few framing words before we jump in.
Great, thanks. And thanks to, as has been said, to staff for the great work to prepare, and thanks to the board members for their engagement, not just today, but always. I guess it's kind of the elephant in the room that it's been a heck of a year. And a lot of things have been turned upside down in challenging ways, but also in good ways, I think. I think it's possible now, as we're moving into vaccines and maybe, at least for the moment, a little bit better climate in terms of cases and disease and fatalities, that there are going to be good things that are going to come from this pandemic, and the work that the board has done over the course of the pandemic and that are in the governor's charge, I think really point to that. I know it's an overused political phrase at the moment, but this notion of build back better. Going back a year and a half ago, when you established a health equity definition and we started about the process of strategic planning, identifying a strategic goal of eliminating health inequities in the state, is work that turned out to be It would have been nice for it to have been a year earlier than it all happened, but it turned out to be really helpful as we went into what has been a deeply inequitable pandemic. And I think we have learned a lot from that. We've already implemented some new tools and approaches that we're going to want to be able to continue using going forward. And you have been great partners with us in helping hold us accountable to that and helping us move that work forward. I think now that we look at some of the things that are in the governor's charge around, Senate Bill 889, cost containment, those kinds of issues, really what I think we can, what you as a board have the opportunity to focus on, and what we are beginning to have the opportunity to focus on as an agency, is that notion of let's look forward. Let's think about how we continue the objective of delivering the triple aim for all Oregonians, but let's now do it with a new set of frames and a new way of thinking about it that's been informed by this pandemic that we've been through, because it's been an opportunity to learn and grow as individuals and as a board. So thanks for your time and your investment today. As always, I have to apologize. There are a couple of points I'm going to have to pop off for a couple of other meetings, but I'll be here most of the time today and tomorrow. Thank you.
Thanks, Pat, so much. What I'd like to do now, folks, is just, and I know you have the materials, you have the agenda, but really to give a sort of overview of the next 2 days and what I hope we walk away with. And so at the end of this 2 days, we hope that there's a shared understanding and an affirmation of board roles and responsibilities, and a shared understanding of the board's priorities this year and kind of what that work looks like. You know that I did pre-retreat interviews with all of you, and then we had a couple of pre-retreat sessions, and those have informed these conversations. A note on the pre-retreat sessions, there was no quorum, there were no decisions, we were within the public meeting laws. We've shared the pre-retreat summary and the list of follow-up items. And some of those items we're going to discuss over the next 2 days, and some we just wanted you to have sort of to see what came out of those conversations. So today is really focused in some ways on level setting, and to that end, we're going to be hearing a 10-year review of the board's work, as well as from all of your committees. And tomorrow, we're really going to shift to more of a conversation about the other priorities. The focus on committees, the oversight of your committees is actually one of your priorities. And in addition, with the governor's letter, she asked you to focus on waiver renewal, as well as the cost growth target work, or the 889 work, as some people call it. And through all of this is sort of lifting up and elevating equity in these conversations. So hopefully keeping those things in mind, the priorities as requested by the governor in mind today as we hear from the committees. And what I hope, so we're going to hear is what I hope you walk away with today. So overall, roles, responsibilities, and shared understanding of the priorities, and today and integrating what you hear today from the committees into that work. And so, as well as the presentation from Steph on the 10 years of the board's work. So I'll introduce the committee work a little bit more when we get there, but we will have time at the end today, which is really important, to focus on sort of how do you work across committees? What are your priorities? What do you want to be making sure you're doing as you do oversight of those committees. So in a minute, I'm going to turn it over to Steph, who's going to sort of give us this opportunity to reflect on the last 10 years. But board members, let me see if you have any questions or comments about the agenda before we get started. Okay. So with that, I'm going to turn it over to Steph and to reflect on the last 10 years. And here's what we wanted to share with you about it. Obviously, you want to celebrate these last 10 years of the work of the board, but also to help inform the work going forward, both in terms of the substance as well as the process. And so one of the things you'll see is we've used that framework of leader, collaborator, influencer, and communicator. And we'll be talking more about that again tomorrow, but we've used that Steph has to create this presentation. And, you know, the board is more than a group of people, right? It's an institution for the last 10 years. And while the composition has changed, the accomplishments still belong to the board, all on transformation and really sort of steering the work of the state on transformation. So with that, I'll turn it over to Steph, who will walk us through these slides. Yes, we can see your slides. So we see the slides, Steph, and we also see your chat as well.
Oh yeah, I think that's Michelle.
Oh, okay.
Okay, Michelle, do you want to switch out and switch back in? Is that better? Give you a chance. Thank you, Diana. And I'll also say thank you for we're going to look at the slides. You also have a document that shows a brief history of accomplishments that is much more detailed than what's in the slides. And thank you for some support that we also got on this work from we've had a really excellent intern, Millie Dibble, who has been supporting some of this work. So thanks to her as well. Okay, so just to kick things off, I'm going to be going through some slides briefly and hoping to allow you all an opportunity to really talk and reflect on some of this with Trilby. But just to give you a sense of what we're going to talk about, we're going to look quickly at some of the successes of the board and your committees, the overall evolution of the committees on the board, which is something that I think many of you have been asking about and curious about. And that goes again to what Diana's point was, that this institution of the board has existed and there have been prior boards that have different committees and different priorities. And so making sure that we have that knowledge for your discussions. We're going to then zoom out and look at the work ahead for the board and the committees in 2021, but then also beyond, reflecting back on a decade and thinking about a decade ahead. And then finally, Trilby is going to jump on and help with facilitating a question and discussion portion of this time. So next slide. One of the things that, when we went back, we actually looked back at every single agenda from the past 10 years of what the board has done, what have we focused on in meetings, what are our biggest accomplishments. And what we found is that you can collectively say that over the years, we've worked on these 5 topic areas in different ways. Lots of overlap, lots of nuance there, but generally thinking about healthcare integration and how we bring our health systems together. Health system transformation has been a huge theme, continues to be a theme. Healthcare payment and costs. So how are we paying for it? How are we reimbursing? What are the costs? All the nuance there. Community and public health have continued to emerge, and thinking about how that interacts with the health system. How is that separate? How do we bring up and lift up the community and our public health work? And then health equity as well. So I'm going to go through and thinking about those different roles that the board has played. We wanted to just pull out a couple of successes from that longer list of some major accomplishments. And I think many of you are familiar with this, but just setting the stage for what's to come for the retreat overall. So some successes with the board as a leader. So the PCPCH model, that's the patient-centered primary care home model. The development of that model really was at the forefront of the board's work, a big priority and effort there, as well as the standards that then were initially lifted up from that work. The establishment of the Health Equity Committee is something where we can see the board having clear leadership in that space, recognizing the need, recognizing and supporting the work driven by our Division of Equity and Inclusion. And then the development of CCO 2.0, which is much more recent. Most of the people on the board now are currently involved in, and I think we have a lot to look forward to as well in terms of the roles that the committees play and that the board play in connecting the dots on CCO 2.0 to ongoing work, ensuring that it's getting implemented as you all envisioned. So the next role that we have talked about is the board as a collaborator. One of many of the areas in which the board has collaborated with us over the years is in developing legislation. I'm going to highlight the one for the CCOs, which goes way back to 2012, but in 2009, actually. I mean, the board had a role prior to the Health Policy Board even being in its current structure on supporting some of the work, House Bill 3650, for example, of thinking through what does legislation need to look like? How do we partner? How do we have those conversations? The board also collaborated with the Early Learning Council for a number of years. We had a joint subcommittee thinking about how the early childhood system and the health system overlap. This is some of the driving force behind our metrics focus on early childhood right now. Really foundational work, nationwide. And then collaborating with the Healthcare Workforce Program, or Healthcare Workforce Committee, on the development of the Healthcare Provider Incentive Program, which is another just enormous success. I think we've gotten a lot of presentations recently on it and just how it has evolved over the years. And I think about the board collaborating and having a really strong partnership role in that work. Oops, that didn't come through the same way. So some role, the board in the supporter role. I think the development of the HITAC, which is the Health Information Technology Oversight Council, one of the subcommittees of the board, the HITAC strategic plan, and its ongoing work in going forward with updates of the strategic plan is a great example. Senate Bill 440, this is what helped stand up the Health Plan Quality Metrics Committee and the whole structure around trying to bring metrics together in alignment across markets. That development was also something where, not led by the board, but the board having a really strong supporting role in that work, and supporting the recommendations that led to Senate Bill 889. And I just think about the board serving as a champion in a lot of these cases and really being able to lift up the importance of all these ongoing efforts. And then our last role that we see the board play over the years is as a communicator. And if we could go to the next slide. Thank you. Oregon State Health Improvement Plan, Healthier Together Oregon, as it's now referred to. There's a great website for that. The SHIP is something that the board, the Public Health Advisory Board, had a much bigger role on. Individuals on our board had a role on, but the board really served as an opportunity to bring that forward, make sure that there was a platform to be able to speak to that. There was a lot of importance in the board serving as a central space to hear updates on COVID-19 response and then following up with that with the community response. We didn't really have a lot of those venues that were quite as public as the board. And so there's a really important role in having the board be available to hear from the public and to generally serve as a space for the agency to be able to speak to some of our ongoing topic areas. And then I think finally the health equity definition, formally adopting this for the agency, formally adopting this for use as part of something that came out of your committees was just a really important role that the board played in communicating the importance of this work and encouraging and pushing the agency to move forward with that. That highlights kind of the different roles, the 4 different roles that we see the board playing. And again, we have a lot more accomplishments that the board has carried forward in conjunction with committees on your additional sheet. I'm gonna point to the next slide, speaking about the committees overall. So currently the board has 8 committees. So these are the 8 committees in the bubbles around the board right here. There are 131 total member positions on those committees. There have also been 20 other committees that have either sunsetted or moved in some capacity as the projects matured. The handout includes the different committees and kind of shows the trajectory of them. Some of them are intentionally time limited, some of them evolved into other things. But you can see that evolution and how committees and priorities of the board have changed or expanded over time. And so I think as part of the retreat overall, we're asking you to consider both your roles, so leader, collaborator, supporter, communicator, as well as the work of the committees and how you are working with them in all those different roles, because each of the highlights that I showed to you was really something that you did in collaboration or leadership or support of a committee in a lot of ways. So in the next slide, you know, when we think about the last 10 years, we think that this is a great way to set the stage for thinking ahead to the next decade. The governor has provided some really short-term concrete priorities for the board, as we've talked about previously, but as a reminder, around Senate Bill 889, which is the healthcare cost growth target work, the 1115 Medicaid demonstration waiver development, and then health equity as an ongoing priority of the board to ensure that work is being connected and that we're continuing to raise that up. That's short term. And then we also know OHA has a strategic goal of eliminating health inequities by 2030. And so I think in just a few minutes, we're going to be hearing about all the other committees, all the priorities of those committees, the work that they're doing. So I just ask you to keep those priorities, what we have right in front of us, as well as our long-term goal, thinking about really what the decade will look like ahead for the board and for the committees and what role the board can play in all this work. So if you go to the next slide, this is just another opportunity for those who are more visual to think about, you know, where we're at right now. We have these short-term goals, we have committees, we have OHA, we have the board, everybody is engaged on this work. And then if you look at the long term, you know, we have a lot of space to think through. That's partly what we want to do at the retreat in the next 2 days, is to really think through, you know, how are we going to get to our goal? What role does the board play? What role do the committees play? So with that, I'm going to welcome Trilby and welcome Diana to jump back in. I certainly have lots of space for questions and reflection and discussion at this point, just to, you know, spend the next 20 minutes really, if I can answer any questions, but also just leave it up to you to have that discussion.
Thank you, Steph. I'll jump in for just a moment here and add a few thoughts. I think this is a wonderful slide deck, and in many ways, I think helps us remember that the current board members, each of you are really standing on the shoulders of past board members. Then there's been a tremendous history of accomplishment by this institution, as Diana phrased it, of the board. And I also, you know, when I look at the breadth of committee work that Steph has shown us, it really also illustrates that you all need not do this work alone. You're never doing this work alone. You're doing it in partnership with these committees, which represent such a rich cross-section of stakeholders and community who are really assisting in the development of policy for OHA. And I think part of our challenge strategically as we plan for the future is how to best utilize the committees to really drive us forward in these priority areas, those being equity, you know, and really, again, thanking the board for giving us that definition. And thank you to Pat, really, for his leadership at OHA and setting up our 10-year goal. And the governor's commitment to equity couldn't be more evident. So it's really what's driving all of us, which feels wonderful to be pulling in the same direction so clearly. And how do we work with all the committees that the board oversees to make sure that everything we are doing is furthering that goal within especially these priority areas of the healthcare cost growth target implementation committee and the waiver that we are beginning to talk through and that we'll be developing over the next months and probably a year. So I will stop there. We really did want to leave you plenty of time to talk to each other about the content of what Steph has shared with you and about where you stand at this moment in time, and how together you want to marshal these resources and build on what's come before. And Diana, I don't know if there's anything you'd like to.
No, Trilby, that's great. And it really is wanted to give you a chance to just reflect or give feedback on what you've heard, what you saw, as we think about this level setting for the rest of our conversation. So I just want to open it up to the board for any questions, any reflections, how you feel it informs your work going forward.
So this is Ebony. The one thing that just initially comes to mind, and what I continue to tell myself too, is as we look at kind of the priorities that were brought forward by the governor, in addition to kind of the core priority of OHA, I keep telling myself too, and how do we look at it strategically from the lens of thinking about kind of the full breadth and scope of OHA, because I think it would be easy to kind of, focus on Medicaid specifically, for example, forgetting to kind of look at the intersection of, that full continuum of care specific to behavioral health as an example, or, how do we think about kind of, the intersectionalities of public health and in healthcare. And so, just initially, like what I'm telling myself is, and how do we keep in mind and look at it from kind of that broad perspective too, just so that we can be transformational, efficient, and strategic.
Thanks, Ebony. That's really helpful. Go ahead, John.
Yeah, first of all, a clarification, I think appropriate since we're level setting. I don't see primary care in one of the bubbles on Stephanie's slides. I do see primary care on the agenda. And one issue for me will be, is primary care in or out? And what is our role when it comes to primary care? The second would just be a comment, I guess. It makes me feel better, I guess, that we are a communicator when it comes to COVID-19 and equity. When I read the Health Equity Committee's letter of September 2020 to us, which I think is in our packet tomorrow, I felt really bad because I didn't think we met their expectations. And I guess I thought back in September, our job was to do more than be a communicator. Now I shouldn't feel as bad. Because, the last 3 or 4 months have been pretty difficult when it comes to COVID and equity. So, I would just say that because it seems like a theme that will come back, especially tomorrow, that must be in our packet for some reason. Really reading that brought that back to me.
Thank you, John. Brenda. Oh, Steph, do you want to just address that and then we'll go to Brenda and then Trilby. Go ahead, Steph.
Yes, thank you, John. I was just going to share that Chris is going to talk about primary care a bit during her presentation. So thank you for bringing that question up. And then we will be sending out an update as promised on those health equity recommendations by the end of today. So a little bit of a scramble because of some power outages for some key staff this week, but we'll be sending that out tonight in preparation for your meeting and conversation tomorrow.
Yeah.
Oh, Trilby and then Brenda.
Yeah, very briefly, but John, we did promise to bring you that update. That was part of the follow-up from your hearing those recommendations from the Health Equity Committee last fall. And so we do have that for you. That's what Steph is referring to. And you'll see that there's a breadth of work going on across OHA that does align with the recommendations from the HEC committee. So we do look forward to having more conversation on that tomorrow. And the various roles that the board is in these different areas.
Brenda.
perhaps that's the segue into my comment, which is recognizing that as an organization, we haven't always been super clear on where.
Brenda, can you speak up a little bit? I think we're having trouble hearing you.
Okay, thank you. And if I get stuck, I'll hold my comment. Can you hear me now?
Yes, we can hear you. Just speak up, yeah.
Okay, will do. First, I want to thank you, and that was a great segue, Trilby, into my comment, which is I think as a board, we're not always really clear on which role we play. Are we a leader in this effort? Are we a supporter, a communicator, a collaborator? And if so, how does that decision actually arrive to us? Or what are we actively doing to sort of stake a claim in any one of those 4 given roles? And so because we had this opportunity to review those definitions in our pre-retreat materials and recognizing that there are many other people on the call who don't benefit perhaps from that definition, I wonder, Diana, if now's an appropriate time for you to speak to that or someone else here to sort of share this framework, kind of step back a moment so we can kind of ground ourselves yet again. Thanks.
I'm happy, we can definitely pull up that slide if that would be helpful as we move into the committee discussion. So if Steph, Tara, or Michelle, if one of you could grab that slide and we can just go over it with folks, because we will, Brenda, we're definitely going to drill down on it tomorrow, and it's great to bring it up now to make sure there's a shared understanding, so appreciate that. Let me see if as we're getting that up, other comments, okay, other comments or questions from the board about the presentation. And the slide we're looking for is that it's not in this slide deck, it's the leader, collaborator, supporter, communicator, that new framework that we'll be using. So if someone could pull that up, that would be awesome. And I can look for it too. But let me see if there's other comments about or reflections. David, please.
Yeah, I just want to reflect on Brenda's comment. Brenda, I think you hit raise a really good point, because that sometimes that clarification has been explicit, like when the governor wrote us a letter about CCO 2.0 and said, these are the priorities I want you to think about. So there's like really explicit guidance that we're a leader. And then other times it's sort of been organic and sort of evolved. But I don't think we've been that intentional about putting it in. Well, first we didn't have the framework to put it in those boxes. I don't know if we always knew exactly what role we were playing. That framework helps a lot. And I think to be more explicit, more intentional about which box each activity fits in, especially as we get involved with more and more different types of activities, is really helpful. So thank you for raising that.
Let me just quickly review this. So this came out of discussions with the board and sort of some thinking that staff had done to get at this exact issue that you all are highlighting. And this has been updated, board, since you saw it last, and I'll share how. But there's this idea that, while you can't always just sort of put the board there, you're always a leader in this, you're always a collaborator, but that this would give a framework for when you're leading, collaborating, supporting, and communicating. And we updated some of the examples of what that looks like. So CCO 2.0, clearly the board was in a leadership position on that. Collaborator, the HEC and the FAB's work, or the provider incentive programs are examples there. In terms of supporter, the vaccine policy statement and the health equity recommendation. Communicator, we talked about the SHIP and some of, when we go to I think when you're in the community, those community presentations, or when you go outside of Portland, I think we were referring to that. Some of the feedback we got from you all at those pre-retreat sessions was this question about influencer. And as we discussed it, and we added this at the top, is that the board influences in all of these roles. There's not a role that they don't influence in. So whether you all are leading, collaborating, supporting, or communicating, you're influencing. So we thought that was more of an overall rather than a separate role. So that's why that's how we reflected it. So this is, and we planned on spending time on this tomorrow in more detail, but I do want to see, while it's up here, I think Brenda was saying, share it with the rest of the folks on the call so everybody knows what we're talking about, which makes good sense. Any other reflections on this before I want to see if there are any other questions or comments about that 10-year reflection, but any comments on this specifically? Okay, so we can, so anything else about the 10 years? So some of the things I've heard about is, making sure that we're thinking strategically and we're being intentional, looking for those issues that are sort of across markets, maybe not just focused on Medicaid, things that cross over like between health and public health. We have this question that John's teed up, which we will be talking about, I think, sort of what's the board's role in terms of primary care. And then this issue of equity and what is the board's role there? Just in general, the question Brenda posed of, how do we think about our roles in these different spaces? And I think some of it's just is going to be dynamic, but at least if there's a shared language, you all can use that. So I'll stop there and see if there's other comments or questions on this. Brenda, please.
Yeah, it's more about the decade ahead and the system of the future as that slide was outlined for us. And my question is about how we're sunsetting our previous work. So I have a passion around behavioral health. I know it was an objective and a key initiative, a key strategic priority for our last 3 years of work. And clearly we're incomplete. Right? We've got plenty of more work. In fact, that goes into, infinity and beyond. So the question I suppose is for this board and this body, when do we make those decisions? Some are governor informed and governor directed. Others are actually sort of at the will of this group. And that's what I wonder about sometimes is how explicit and defined we are about what we feel complete or semi-complete with, or we've handed off to another body. That remains a question for me, something I hope we clarify by the end of the retreat.
That is specifically on the agenda for tomorrow, is what about that other work? It still exists out there. So appreciate you surfacing it, Brenda. And we'll be talking about it tomorrow. It doesn't mean it can't come up today, but we specifically have an agenda item on it tomorrow.
I guess I have an operational question too for, maybe staff or board members who've been on the board even longer than I have. I've been on the board a few years and we've never had a conversation about potentially sunsetting a committee, and what does that look like? I'm curious to know from before, like maybe 5 years and before that, if there has been sort of like a thoughtful approach or conversations, decision-making to say, we're done here, we're good, or we're gonna put this over here and then we're gonna add this instead. So I'm just kind of curious if that's occurred in the past.
Steph or Jeremy, do either of you want to weigh in on that?
I mean, it's a good question. We have had, sometimes the committees start with the expectation that they are time limited. So we know that they are going to, when they complete their work at a certain date, when they share their report or their recommendations, that's kind of it for the committee. Some of them have morphed into existing work. So like the PCPCH team and that work was driven by a small work group under the board made up of OHA staff mainly, reporting to the board. And then it has, over time, it has developed into a full program as an example. So I would welcome other input from other OHA staff, but it's a good question. I think we currently don't have a great way of evaluating, what is the purpose. And then of course, some of them are statutorily required too. So that would require a legislative change at the state or in some cases the federal level for us to do that.
Yes, Jeremy, I just say stopping having a committee is not a thing that we've been particularly good at the state. I think we tend to add them and don't usually tend to ever wind them up. But we have, one example I can think of is there's in statute, actually, there's a public purchasers committee of the board. They worked for about a year. Their scope was really trying to do some aligned contracting for local governments. There was a charter to do that. That work kind of came and went and ended and hasn't really continued on. And so it was sort of they had your work plan and that was kind of that and hasn't continued on. But, I think part of the reason that we are having this scope and prioritization challenge is because we do keep kind of adding more and more and more. We haven't a lot of times said, okay, we've kind of ran the course on this and we're done.
Thanks, Jeremy. Oh, go ahead, John.
Yeah, you know, that reminds me of another issue that I'm quite proud of, and I think as a board we should be proud of. I think as part of CCO 2.0 and a previous governor's letter, we really focused on children. And, you know, there's a group of folks who have really advanced that agenda. They've done an incredible job in terms of performance measures. You know, in some of the materials, I noticed that nobody mentioned the performance measurement that group has developed related to children, which is just superb. And in fact, that group has probably been the most successful at developing new performance measures. You know, that said, they're not listed, and perhaps it's because they've been so successful. They may not need us. You know, on the other hand, I think of behavioral health, and they seem to still be struggling. And, you know, maybe we're not the appropriate folks to help them because they're still struggling. So I think I would, you know, be more concerned about, you know, folks who are really important to the future and are struggling. While I would miss getting a chance to see the folks who do the children's stuff because they've done such a wonderful job, but they're very, very, very capable of getting the job done.
One of the things I'm hearing is, and I think, well, as I say, we'll be talking about this more tomorrow. I want to get us hearing from the committees in a moment. But one of the things is sort of what does happen to that other work that either you did or is transitioned, or and to Oscar's point about committees. I mean, is there an assessment at some point that you all say, you know, maybe we don't need that committee anymore, or maybe it should be spun off from the board? And what is the process for making that happen? So I think we can put a pin in that as we hear from and talk about the committee work. And tomorrow, when we talk about what comes off your plates, if anything, and where does it go? Mm-hmm. I want to shift us to this, and this is actually a great segue. I mean, so all this oversight of committees is a significant body of work. And one of the reasons for sort of having all of your committees come before you today, even though it's going to take a while and it's a lot of people and a lot of information, it's really important. And it's, you know, when you think about a retreat and what you're supposed to do at a retreat, it's actually sort of stepping back and trying to get a bigger view of what you're trying to accomplish and all the things that feed into that. And so what we hope is that what you're going to hear in the next couple of hours really does give you that comprehensive picture. We also see it as an opportunity to continue to build those relationships between the committee, the board, and its committees. And hopefully a lot of the different committees are going to be hearing from each other. And there's this opportunity to try to identify connections across the committee work. A couple of other things is you all usually get a committee digest report in your retreat packet, but the staff and the committee chairs worked with the board chairs and said, we'll bring board quarterly updates through the year, because monthly was like too frequent and there was redundant information. So you're going to get those quarterly. So Tara wanted me to be sure to share that. But as you listen in the next couple of hours, and we're just going to go through the committees, is think about, you know, we are going to have a conversation at the end after all the committees to sort of lift up some of the big themes. But if you have specific questions for clarification, please feel free to ask those after the presentation, any specific comments on the work, but please do be jotting down, and we'll be doing the same, sort of any themes, or think as you think about how the board can most effectively support your committees. I'm going to be the timekeeper. I'm going to apologize in advance that I'll be cutting folks off in their presentation. Melinda's smiling. I'll be, you know, give you guys 5 to 7 minutes per presentation, and then want to be sure there's a few minutes for the board to weigh in. And we do have some flex time. So board, if I don't want you worrying about time, I'll worry about the time. We may have a little bit of flex if there's a place where you want to dig in and get a little more information or tee up for later on. Staff will be taking notes to make sure if there are items to capture that we do that. So with that, I'm going to start running through the committees, and I know for the first one we have is Health Plan Quality Metrics, and we have Melinda Muller and John Collins who are going to be walking us through that, and I'm going to turn it over to the two of you.
Great. This is John. I just want to check to make sure you can hear me okay first. All right, cool. So, hi, I'm John Collins. I'm the chair for the Health Plan Quality Metrics Committee. And Melinda, you want to introduce yourself?
Sure, I'm Melinda Muller and I'm an internist at Legacy Health, and I'm the vice chair.
Thanks, Melinda. Oh, and just by the way, I am an employee of the Oregon Health Authority. I'm the deputy director for the Health Systems Division, and I'm the OHA representative on the Health Plan Quality Metrics Committee. The Health Plan Quality Metrics Committee was basically started out of Senate Bill 440 back in 2015. And we were established to try and create some control over the types of metrics and the metrics that were available to do a lot of the different work that was performance metric work that was going on at the time. And what we do on an annual basis is establish a menu of metrics that are available for the Metrics and Scoring Committee to choose from and track the CCO performance and the incentives that are awarded based on that performance, as well as the PEB and OHPB boards must also choose measures that are approved by our Health Plan Quality Metrics Committee if they're going to utilize them with any of the plans. There's an additional role associated with I'm blanking on the other group, Melinda.
Oh, metrics and scoring?
No, beyond metrics and scoring. There's a fourth group actually beyond PEB and OHPB and the CCOs that utilize.
Not DMAP, but DCBS.
Yeah, DCBS, I'm sorry. And I kind of stumbled on that because actually our role with that group and the metrics they utilize has always been a little bit up in the air since it's not a board or a controlled group like we're dealing with for PEB, OHPB, and the CCOs. Anyway, as I mentioned, can you go to the next slide? The group itself is statutorily defined, and this membership is statutorily defined in terms of categories. And we've been moving along for the past 5 years pretty well. We had to go through a number of initial work to establish criteria for measure selection. But once we got past a lot of that work, a lot of it's been about maintaining and making adjustments to that measure and menu set. This past year, one of the things that we did, I think that was one of the biggest things that we've been able to do, is make it an addition or an adjustment to those criteria that allowed for us to select what we refer to as transformational measures. And in effect, what that allowed us to do is go beyond our typical process and looking at measures that are approved by national boards and other groups and open them up to things that are filling in gaps for Oregon that need to be established, and or things that aren't traditionally measured by and endorsed by the various national groups. And how we open that up is that while we still want to have validity associated with anything that we put forward as a measure, we allow for that validity to be established and continue to be established even as we endorse a measure. And some of the evidence that we allow to be presented to help us endorse the measure goes beyond the typical types of rigor that's typically associated with a metric, and opens it up to consumer experience and other groups' experience. And we actually added a couple of measures to our menu set this past year that allowed us to utilize these criteria. And Melinda, do you have anything that you'd like to comment on that? Any color commentary?
I don't think so. I think just on the transformational measures is really trying to get to items, especially when you look at equity and to the point of cultural sensitivity. A lot of times there's not a claims data point with that. So how do we measure it in a way that moves things along, but it gives us a little bit more flexibility?
Exactly. Can you head on to the next slide, please? So, what we're doing currently, we went on break for a little while during the pandemic, as a lot of the individuals who participate on our committee are direct healthcare providers or involved in some way or another in the healthcare field, and it was not feasible to bring everyone together, at least not in terms of having a full quorum. So we went on a break, and we just recently had our second meeting returning from the break, and we have our short-term goals associated with that, which is, again, to make sure that we have a measure set available to the Metrics and Scoring Committee and to the PEB and OEB boards by roughly around April, so that they can utilize that set to pick and change any types of measures that they want to use for performance measurement. And that's really what we're focused on here in the short term. I think long term, there are other issues that we probably need to address. And quite frankly, we would love to hear from the policy board and helping us set some of our goals and some of those issues that we should address. So I think that's about it, Melinda, unless you have other things to add or the board has questions. Oh, and I almost neglected to mention, John Santa is our liaison from the board and has been from the beginning of the Health Plan Quality Metrics Committee, and has done a great job and is invaluable to our committee in helping us basically level set and keep us focused on issues that are relevant to the policy board. Thank you.
Thanks, John. Thanks, Melinda. Let me see if folks have questions or comments for John or Melinda. Okay. Oh, Kirsten, please.
I think the work of this committee is so important, and I expect it to remain and grow in its importance as maybe more parts of our state look towards this menu for guidance. So I really appreciate the effort here, and thrilled to learn about this kind of criteria that was formed in 2020 for perhaps creating more space or guidance for adopting transformational measures, because I know that that has been a challenge. I guess I would love to hear from your perspective, if you feel like that you have the space to do transformational measures, or what support would be needed.
That's a great question, and I think it's particularly applicable to the transformation measures, but probably some of the others as well. And the board is essentially, the committee is essentially in a place where we evaluate measures that are brought to us. And anybody can bring measures to us. Our timelines are a bit condensed this year, but typically we would have a whole lot more time to review those. What we don't have is any kind of resources to direct and or fund, if necessary, those type of measures. So when someone brings forward a transformational type measure to us that we're interested in, and we even adapt, some of the data that might need to ultimately be collected on that is very dependent on whoever brought us the measure down the line. I think that's been a real challenge for us. We can explore gaps on our own, and I know members of our committee would probably bring up dozens of different areas, but we don't have the resources to explore those without them being brought to us by an outside entity. Melinda, I don't know if you care to add on to that or not.
Yeah, I think the other, so I think the transformational measures is one bucket. I think the other bucket is even with some of the, I'll say non-transformational measures, so some of the kind of normal stuff, there's what's out there to actually measure things. So for example, depression screening, which is not considered what quote unquote transformational, but the ways that the measures that are out there that actually measure depression screening actually don't really get you to improvement in depression, because the way what the data is that you can collect is so limited. And the ones that are really actually get to is the person actually better. Trying to collect that data even from a clinical standpoint within the clinics is so complicated that while we would love to go to that item, we don't have the clinics themselves don't have the bandwidth. And so then we don't have the data, we don't have the capacity to say, is there a different way to collect that data that lets it be more doable? So I think it's both a data collection for the transformational ones, but in some cases is actually regular stuff that we feel if we collected the data in a different way or looked at it a different way would get us further, but we just don't have the capacity to do that.
Brenda.
Just a clarifying question. I can see how this particular committee interlocks pretty effectively with metrics and scoring. And as I think about the board's committee structures, are there other working relationships between this committee and others that could be improved, or that you think, yeah, I'll just start with improvement.
Well, I'll go first on that. And I mean, officially the way, and when Senate Bill 440 came out, it moved metrics and scoring to a subcommittee of the Health Plan Quality Metrics Committee. Structurally, I don't know that we've really ever explored that too closely, other than the fact that the menu set that we develop basically puts parameters around the work that the Metrics and Scoring Committee does. We do have back and forth a lot of times, like if Metrics and Scoring itself has a measure that they'd like to bring forward that somebody's brought to them, you know, they work with us to make sure it gets on the menu set or allow us to evaluate it. Outside of that, we've also worked with the Equity Committee, and that was part of the work and that relationship that went into adapting the selection criteria that we have for those transformational measures and opening up the door for a broader set of measures that didn't fit into the traditional pieces. And we will be looking at cost containment type measures this particular over the next couple of months. I forgot to mention that earlier. So, and we're getting some background at our next meeting in a couple weeks on that work so that we can evaluate it better. So there has been some where there's a dependency on metrics, but there probably are some other committees where we haven't explored that relationship that maybe we should look at and would be interested from the board for missing some opportunities out there.
The only thing I would add related to that is we have looked with the public health piece, because recognizing if we want to move upstream, that's where we need to move. But you know, thinking about metrics that you can actually measure on a individual or kind of health plan basis, at that point it's even more complicated. So we're interested in working more with that, but haven't done a lot just because some of the limitations.
John, go ahead, and then we're going to move on to metrics and scoring. But John, please.
Yeah, just for the board, I mean, realize HPQMC, as Melinda just said, has focused on health plans, not hospitals, not physician groups, health plans. And as John said in his opening remarks, their focus has been CCOs, OHPB, PEB, and now a little bit DCBS. 889, where some of the quality and ethics work could come their way, is Medicare, commercial, Medicaid, it's health plans, it's hospitals, it's doctor groups, and it's cost. So there is a very large amount of measurement potentially here, and I suspect that will need to be done by a variety of folks, either helping or taking pieces and doing it. This is really a big piece of work.
Okay, well, thank you so much, John and Melinda. Thanks for those board members for those questions and comments. We're going to move now to metrics and scoring, and we have Amit Shah and Summer Prantal-Noodleman who are going to be presenting on behalf of the Metrics and Scoring Committee.
Well, thanks for having us here. I'm Amit Shah, and I am Chief Medical Officer of Care Oregon, and I also chair the Metrics and Scoring Committee. Summer, I think you are on as well.
Yep, good afternoon, everybody. Thank you for allowing us to present today. My name is Summer Prantal-Noodleman, Vice Chair of the Metrics and Scoring Committee. I am one of the 3 CCO representatives on the committee, and I'm a Senior Manager of Operations and Quality for the Eastern Oregon Coordinated Care Organization, or EOCCO for short. And the Metrics and Scoring Committee was established in 2012 by Senate Bill 1580. As John Collins outlined, in 2015, House Bill 440 made Metrics and Scoring Committee a subcommittee of the newly established Health Plan Quality Metrics Committee. So the Metrics and Scoring Committee met in 2020, taking a pause on just a couple of meetings. And reflecting back on 2020, a couple of committee actions have really stood out. So the first highlight would be the inclusion of the health equity measure, which is meaningful access to healthcare services for persons with limited English proficiency. This is the measure that the Health Plan Quality Metrics Committee outlined as a highlight in their presentation. The measure is part of the current 2021 measure set. The second highlight is the developmental work of the committee, specifically supporting efforts to leverage the incentive program to address social determinants of health and health equity. This includes the development of measures supporting a multi-measure, multi-year kindergarten readiness strategy, and the development of measures incentivizing a social determinants of health screening. So next slide, please. So what are we working on now? Our current work includes the committee's statutory obligation to select incentive measures and targets for the CCO Quality Incentive Program. Measure selection occurs on an annual basis, and the committee will be selecting the 2020 measure set by August of this year and targets and benchmarks by October. And to go over the committee's future work and the rest of our presentation, I'm going to pass it over to the committee chair, Dr. Amit Shah.
Thank you, Summer. So for the future work, as you could see there, really we're trying to figure out how to move beyond the medical model with the introduction of framework and strategies around social determinants of health and equity for use in measure selection. And, it's thinking really about what would that framework be? And how could you structurally have a framework to move beyond that medical model? We do need a framework for selecting incentive measures which support this type of transformation, and that's going to be a lot of our future work that we're going to be doing. Next slide. So this picture I really enjoy, and in the committee we spend a lot of time, especially with our OHA support, on really developing it. And we're trying to give a sense of the landscape, the picture of the incentive measures over a framework of health equity. And it's trying to show you where upstream and downstream and the root causes of socio-ecological and some of the issues of root causes of poor health outcomes due to health equity, the social determinant space that's there, and the medical model, where a lot of the work concentrates on. And you can see that we're trying hard within the Metrics and Scoring Committee of looking at our metrics and seeing where do you see the weight. And you could see the weight of a lot of the metrics have been, in that medical model downstream space. And a lot of that was because of data and how one could first start off doing. And the goal is to really start moving some of these measures in there, to a space of upstream. And you could see examples of that new in 2021, the health equity language access measure, tremendous amount of work to put that together. Going into 2022, 23, multi-sector interventions to prevent obesity. looking at 2022 kindergarten readiness, which is really so much about social emotional health and well-being. 2023, building on the kindergarten readiness for follow-up and developmental screening. And then really in 2023, thinking about those SDOH screening and different pieces that are there. And so I think that this map overall helps us, and I think should hopefully help others really see how we're thinking about it in one picture of how we can move a lot of those measures from just the pure clinical model to areas that are more transformational. Next slide. So where can you help? And, I think so many of the insights and things that have come out of this have been so helpful for the committee and helping us, get to some of the hard decisions that have to be made. And a lot of the times the guidance that will really help us for measure selection that could meet some of the broader goals that you have is, this notion of what is transformation, like the definition of it. We spent several committee meetings really discussing it and saying, when we talk about transformation, what is it we're looking for? I think it was Melinda earlier who was talking a little bit about transformative measures and using depression as an example. So getting ourselves really clear that, when we think of measures that we're doing right now, are they really transformational? And if the answer is yes or no, what do we mean by transformation? What are we trying to achieve? How does the board view the CCO quality incentive program in aligning with this definition and meeting this goal? How do we balance transformation and quality improvement with the burden currently faced by providers? As we push transformation and incentive metrics and more measurement done, we know the burdens providers have had through the pandemic, wildfires, all the different stressors that have happened over the past couple of years. And then how does the board feel health equity metrics and incentive metrics will fit with the overall CCO performance? How does that all intertwine together? And these are some of the questions that we talk about and are trying to answer and would love support and guidance around that piece. So I will end there and say thank you so much for giving us the opportunity to meet, to be able to talk about all of these things. It's a great committee with wonderful people and amazing OHA support. And it's an honor to be able to serve on it. And we really appreciate the time you're giving us to be able to share the work we're doing and some of the thoughts that we have.
Summer and Amit, thank you so much. David, go ahead.
Yeah. Well, Amit, Summer, I am so thrilled to hear that you investment in social determinants of health because it was one of the most exciting things for me about the CCO 2.0 discussions that we were going to make that a priority. It was in the governor's letter. My biggest concern about our final product is there wasn't a lot of definition as to how much that investment should be, what type of investment, and the plan was let CCOs experiment and then we'll learn from that. And I think bringing a measure to this will provide really urgently needed clarity as to what's working, what's not working. And so I really champion you, celebrate your work on this, and please keep going forward. I would like interested in your thoughts in terms of support from other committees, because I see Public Health Advisory Board has a real supporter of this work, as well as the Health Equity Committee. And there's a lot of synergy between the three of these committees, and anything we can do as a board to facilitate that, please let us know. And I think it's really important for us going forward because the governor's asked us to focus on equity, and equity is an upstream social determinants of health issue, and that this is really central to one of our our North Stars that the governor has put forward. Thank you all, but I guess the question to you is, how can we encourage crosstalk with the other committees to really move this forward and help you and support your work?
Yeah, I appreciate all those comments and insights that you have there. And I think it really aligns what all of you have been discussing, and it is trickling to our committee, your insights and focus. I think the great part that's happened over metrics and scoring since my tenure in it, even predating when I became the chair, we've been doing a lot of work, the chairs and the vice chairs and the OHA team that supports us, around really being deliberate around the various committees and making sure we cross-pollinate and share, because, for one way or another, metrics and scoring committee, probably similar to other committees, has a lot of tentacles in different places, and it really requires a lot of levels of support. And the various committees that have been set up through this board have actually been really helpful from my perspective for metrics and scoring, because it's pretty easy for us to bring people from those committees who are experts in this field, and they come and they help us, you know, make these really difficult decisions or think about things in a different way. And the work that's produced and the collaboration that's produced it's pretty outstanding. So I feel, you know, that the cross-pollination of the different committees and working together is something we want to continue to promote in our committee. And Summer and I and the OHA team always make that part of our agenda of how we can continue to really promote that, because I think it makes a much better product in the end, especially with how difficult some of these, you know, to really come up with metrics, you know, in a transformative space is not an easy space to do.
Thank you, Amit. Okay. Thank you, Summer and Amit, so much for that. And already I'm hearing a theme across these two is how are committees talking to each other and working with each other. So we'll be sort of continuing to think about that. So Summer, Amit, thank you so much. We're going to go to the Public Health Advisory Board. Rebecca Thiel and Kara Biddlecom will be representing that committee. Take it away.
Yes, good morning or afternoon. This is Rebecca. I don't know, Kara, if you're on.
I'm here, Kara.
Yes, she's there.
Oregon Health Authority. Go ahead, Rebecca.
Sure, thanks. Thanks for having me this afternoon. Rebecca Thiel, Chair of the Public Health Advisory Board. So I'll start off by sharing that the Public Health Advisory Board, or FAB, was moved under the Health Policy Board in 2015 as part of the passage of sort of the landmark public health modernization legislation, House Bill 3100. But before that, there's been many iterations of this board, sort of dating back through like the early 2000s, but officially under your committee starting in 2015. And thank you to David for being our liaison from the chair perspective. I think it's been really, really helpful to have that direct link to the Health Policy Board, and David's very engaged, and so I really appreciate your support. So in terms of committee highlights, specifically thinking about things recently, in October of last year, we updated our health equity review policy and procedure, and we made our commitment to the public health system from our board perspective to really lead with race in all of our work in identifying our priorities, not only from a measurement perspective, but also a funding and prioritization perspective. And one of the ways that we've been operationalizing this work is really taking a look at our subcommittee structure. So the FAB is a statutory committee with designated seats in statute. But we have a lot of flexibility with how we structure our subcommittee work, which is really sort of the meat of the work that we do. And we're engaging in a strategy where we're actually going to be working with non-board members and committee members and community members in that subcommittee work. So really excited about that as sort of a recent highlight. In 2020, we finalized our annual Public Health Accountability Metrics Report. So again, lots of crossover with the previous two committees, where we've highlighted both the work of the public health system in terms of modernization, and also in terms of how funding has been used to support the public health system. One of the things that we'll highlight here is there was great successes and achievements with childhood immunization rates as part of the work with emphasis on local public health and working with providers and getting quality improvement initiatives in place. And so that's just one example that's highlighted in that report that I wanted to highlight for you today. So if we go to the next slide. So in terms of our current work and future work, our health equity policy and procedure is sort of one of the ways that we're going to continue to engage with our board and subcommittee members. But something that we're really excited about for future work is our public health strategic data plan. A lot of public health data is grounded in sort of old methods, non-modern methods of data collection, such as landline phone surveys and other things to understand trends that are happening in public health data and things like chronic disease rates. And so really taking a look at the data that we use to inform decisions. So really excited about that. And then continuing to look at implementing our 2021-23 modernization investments if those pass in this coming session. So I think in terms of health policy board support on the next slide coming up. So for this year, we'll be doing another round of updates to our accountability metrics and thinking about how we want to review those metrics, how we want to look at the state health improvement plan, how we want to think about integrating social determinants of health and health equity focused measurement into how we're keeping ourselves accountable. And then looking towards 2022, again, that strategic data plan, we'll be chartering a subcommittee with community members to think about how the division collects and analyzes data and shares important public health information. So Kara, I will turn it over to you to anything that I missed or didn't highlight.
You did a great job as always, Rebecca. So it might be good to take questions from the board.
Great, thank you, Kara. Thanks, Rebecca. Comments, questions from the board, anything specifically that you all want to lift up or call attention to or need clarification on? Brenda, please.
I just want to give voice to the notion that in a pandemic, this body of work has probably never been more timely and illustrative of the importance of redefining the notion of what public health actually is. And recognizing that I think the state has taken a narrow definition pre-pandemic and has expanded its view and scope of the importance of it now. My question and hopefully my recommendation is that into the future, we can look back at what we're currently living, what we lived in 2020, what we're living in 2021, and continue the focus around taking those best learning opportunities and dropping them into future work plans. So while it's not explicitly stated in the 2022 intentions, I'm wanting just to make sure that it's the one place for this board where I see that anchored most prominently is in this committee. So I wanted to give voice to it now.
Thank you. Ebony, please.
Yeah, and I just, what I just want to highlight and appreciate is, kind of the call out and the visual showed it around just how the focus really has been downstream and, focused really, deeply rooted in the medical model. But then if you think about, what we're called to do as a public system and, the priority populations that we serve and who they are, and what they bring, there's that direct dissonance. And so again, I just think that that visual and call out really makes a lot of sense. And I just appreciate just, I'm hearing that there's the focus around leading with race and just as we're talking about equity, leading with race, being able to also say that in part of the challenge or blinders have been, being overly focused or reliant on the medical model. So just want to appreciate that. So thank you.
Thank you, Ebony. Okay, Kara, Rebecca, thank you so much. We're going to go now to the Health Equity Committee, and we have Derek DeVivier and Kate Wells, who are going to be presenting on behalf of the committee.
Yes, good afternoon. Thank you for having us here. My name is Derek DeVivier. My pronouns are he, him, and his, and I am a co-chair of the Health Equity Committee. Kate, would you like to introduce yourself?
I know she was just here. I just saw her.
I just saw her too.
I am here.
Kate.
Sorry about that. I was, anyway, the mute thing. Kate Wells, and I am also co-chair, and my pronouns are she, her, hers. Also in my work life, I'm Director of Community Health Strategy for Pacific Source.
Great, thank you. So I'd like to begin by stating that the events of the past year have demonstrated the vitally important nature of the work of the Health Equity Committee. COVID-19 and the disproportionate burden of disease in marginalized communities has elevated the national consciousness with respect to health disparities and structural racism. The killing of George Floyd and other men and women of color, in conjunction with the high death rate of COVID-19 victims in communities of color, resulted in the national recognition of racism as a public health crisis. Public discussions of COVID-19 testing, crisis care guidelines and their application, vaccine testing and vaccine rollout in communities of color during a period of mistrust are all equity and social justice topics that have been superimposed upon the regular work of the Health Equity Committee. In addition, logistical challenges due to state meeting regulations have added to the headwinds the HEC has worked against over the past 12 months. During the past year, members of the HEC have engaged on topics including COVID-19 response recommendations, supporting a declaration of racism as a public health crisis, the centering of crisis care guidelines on equity and recognizing the impact of racism and structural racism and the underlying impact of health disparities in marginalized communities, reviewing an obesity metric and providing feedback on the impact of bias and avenues to achieving an equitably centered metric, providing input on the Health Advisory Board Health Equity Policy and Procedure, and representation on numerous committees, as well as presentations and testimonials on a number of statewide committees. This list is not exhaustive. Moving forward, the HEC would like to continue to strengthen relationships. We would like to position ourselves as an advisory body based on areas where OHPB needs guidance and requests guidance on health equity. This would include, for instance, supporting OHPB with its priority areas, including the 1115 waiver. The FAB interaction last year is a model of engagement with committees, which we would like to build upon. Other examples include HEC representation on the State VAC Committee and representation on the Racial Justice Council, as well as its Health Equity Subcommittee. And lastly, the work done by the HEC to provide advice during statewide discussions of equity with respect to the writing and application of crisis care guidelines. Although COVID-19 will continue to require attention over the coming year, the crisis is still very much alive in communities of color. We will continue to work on the health equity definition framework and begin development of a toolkit for other committees of the board. It is believed that this will in turn help OHPB committees in their work to operationalize the health equity definition. Other topics that we will work to engage on include behavioral health and the work that will take place around Measure 110 and its impact. In the same vein, we will begin work around future engagements with the OHSU behavioral health equity staff at OHA. In addition, it is our intention to begin discussions and engage stakeholders, including community members, around workforce diversification in mental health delivery, as well as other areas of the healthcare delivery system. Lastly, we will organize and hold a retreat in 2021, as well as conduct elections for co-chairs. In conclusion, 2020 has been an unprecedented year. A worldwide pandemic that has resulted in a disproportionate burden of disease in communities of color, the pulling back of drapes hiding the unjust existence of health disparities in marginalized communities, a national awakening to the impact racism has on health and well-being, and a clarion call to aggressively address it, have all underscored the importance of the work of the Health Equity Committee. As we move forward, we will continue to work toward the achievement of health equity for all Oregonians. That is, achieve a condition where all people can reach their full health potential and well-being and are not disadvantaged by their race, ethnicity, language, disability, gender identity, sexual orientation, social class, intersections among these communities with identities or other socially determined circumstances. And the HEC is committed to the ongoing collaboration of all regions and sectors of the state, including tribal governments, to address the achievement of health equity. So I'd like to hand it over to Kate if you have anything to add.
Great.
Yes, I know.
Go ahead, Kate.
I need a clicker. I don't have anything else to add, Derek. That was very well stated. So we can just move on to questions.
Great.
That sounds good.
Comments, questions from board members? Go ahead, Oscar. Oscar, then John.
Just a comment. I was really happy to hear that, you know, the HEC thought that the collaboration with the FAB was a successful one in terms of getting some of your work to move forward. I think one of the things that I'm hearing is, you know, other committees report out that they're really relying on the Health Equity Committee to sort of help improve their work and guide their work. I remember when we were structuring and setting up the charter for the Health Equity Committee, one of the things that I think we specifically called out in the charter was that the importance of this committee to collaborate and sort of like, you know, work with other committees. And now I'm sort of like wondering if, you know, if that sort of, you know, encouragement and structure and expectation on the charter should be something that we should explore in the other committees as well, that they will sort of be like, you know, expected to collaborate with other existing committees. So it's not just something that is called out in the Health Equity Committee. Just a thought.
Thanks, Oscar. John.
Yeah, just thank you for all your work. And I know in your work, you emphasize the importance of accountability, and accountability requires measurement, and measurement requires data. And, you know, it's been very frustrating the years I've been on OHPB, all the difficulties related to collecting data. We need all the help we can get, all the advice you can give us. I look at the vaccination report every day, and 60,000 people report their race is unknown. And actually, I saw a piece today that suggests that's a better reporting rate than across the country on average. So we just have real problems. So, you know, starting with Real D, we're all trying to report Real D, all the help you can give us around data so we can measure, so we can create accountability when it comes to equity would be appreciated.
Yeah, sure. I mean, absolutely. I think that that just brings to light the importance of the collaborative nature of this work, that to achieve that type of data and that granularity is going to require a multi-pronged approach with input and expertise from many different stakeholders. So collaboration will be key, and that's where we're headed.
Yeah, and I was just going to add to that, you know, part of, and I do think Oregon with Real D data is ahead of the game somewhat in this space, but we still need to sort of get over the hump of it being socialized enough and sort of standard work enough so that our members and those that are reporting or self-reporting their race or ethnicity are educated and understand why it's important and are feeling more comfortable doing that. So it's a two-sided coin. So when you ask for help, one of the things we might be able to think about is how do we ask those questions? What kind of education do we give? How do we make the recipient of those questions feel comfortable in answering that? So I think there's a lot of work to unpack there, but it's a really important point.
And I just wanted,
please.
I just wanted, you know, give you all kudos for your courage and your boldness, your commitment, your dedication. Just because, you know, I think we all can think of the various kind of stories or times where, you know, there was kind of pushback at various points, you know, coming from, you know, wherever. And so again, I just appreciate that. And, you know, I want to also just ditto to what Oscar said in terms of, you know, how do we kind of thread the needle throughout all committees. And, you know, I think far too often, you know, and it's not necessarily intentional, but, you know, we find that some of the racial equity work specifically ends up kind of being siloed, that then it's easy to just say, we're going to take it to that table, or if they don't say anything, then, you know, we'll leave it to that group. But how do we have that intersection and to assure that there's that connective tissue throughout? So I do like that idea of, you know, saying and, you know, making that recommendation around expectation that all the committees are, you know, interfacing and engaging with the HEC committee. And there's one more thought that I wanted to say, but I forget what it was. I just get super excited about this effort. And, you know, that's what I was going to say. And, you know, for far too long, you know, we have folks that continue to suffer. And I always will say this. And so while we are working to think about how do we hold ourselves accountable and get to greater places of racial equity, until we do, we still have people that are suffering. And so it's a privilege to even be able to sit around and talk about this.
Thank you, Ebony.
Thank you.
Thank you.
I guess I do have a question for the co-chairs. I'd be curious to hear about whether you have the resources to be successful in the work that you're doing. I feel like, you know, health equity has been prioritized by the governor. We have a really big, audacious goal about ending health inequities in 10 years. I want to hear, and maybe this is, you know, not an unfair question to pose right now, and maybe it can be something that you can kind of follow up at some point later down the line. But I'd be curious to hear about the resources that you and the committee needs to be successful and to help us in OHA be successful.
Well, I will never say that we don't need more resources. I mean, I think that's just a given. So there's opportunity for more resources, happy to have them. I think that we work very well with the resources that we've been allotted. I think that as we move forward and we're talking about doing more collaboration and expanding the reach and centering health equity, and as the OHPB starts to focus on its goals and where we can help, there will probably be need for more resources that will help. But I think that's something that would require a more thorough response. But once again, there's always a need for support.
Yeah, and I would just sort of add that, you know, this is a committee of really passionate volunteers that work on these issues. And as Derek said, we've dove into this work. I think the discussion could be resources for the committee, or it could be what kind of resources can we put back into the community. And based on actually the health equity definition that looks at how do we redistribute our resources so that we can, for example, with COVID, make sure that we have culturally comfortable and relevant vaccination sites, education in the community, this, that, and the other. And I think I, again, would not, and as well would not say the committee would turn away any resources, but we would also love to be a part of the conversation to figure out how we can really operationalize that aspect of the definition so that we're making that work come to life in the community.
You know, and I think it would also be appropriate to ask those who support the committee and the work that they do behind the scenes, which quite honestly is enormous, and we reap the benefits of, what type of additional resources that they can use.
Great. Thank you so much. Thanks to both of you for the presentation. And we'll be talking, obviously equity is threaded, as Emily said, needs to be and should be threaded throughout all of our conversations today and tomorrow as well. So thank you. We're going to go to Chris DeMars, who's going to talk about the Primary Care Payment Reform Collaborative. This is the, no pressure, Chris, it's the last presentation before a 10-minute break. But we'll go through this. We do have time for questions, but go ahead, Chris.
Thank you. Hi, everyone. I'm Chris DeMars. I'm the director of the Transformation Center and deputy director of the Delivery Systems Innovation Office. And I am obviously an OHA staff person. And the reason I'm presenting instead of someone from the committee is we actually, for this collaborative, don't have committee leadership positions. And the Primary Care Payment Reform Collaborative has been convened by OHA since it was established in legislation in 2015, and then the charge was updated in 2017. And the charge is threefold: to increase investment in primary care, move primary care payment from fee-for-service to value-based payment, and align payment across payers and providers. There are over 40 members on the collaborative that represent payers, providers, consumers, and other stakeholder groups. And just to echo a comment that John made when Steph was presenting about the committees, it is true that the Primary Care Payment Reform Collaborative was not on the slide. And the reason for that, as I understand it, is that since about 2017, we've thought of the connection as having a dotted line. We are required to submit a report to the Health Policy Board and the legislature per legislation. And so because of that, we want to have the connection and alignment with the Oregon Health Policy Board, but are not as of now an official committee. So thank you for Michelle to move into the next slide. So recent highlights. We recently made clinic attestation to the patient-centered primary care home standards available to all payers, and this data can inform their value-based payment development, their contracts with providers. So for example, if a PCPCH clinic has attested to having integrated behavioral health and primary care, the payer could establish a value-based payment model that's designed to further support that kind of integration. And then another recent highlight is that in the middle of 2020, we started to more intentionally focus on incorporating equity into the collaborative's work. And we have more recently honed in on two specific strategies that still need to be fleshed out, but in general, considering how to sustainably support via value-based payment traditional health workers within primary care, and then also leveraging the patient-centered primary care home program to improve health equity. For example, potential recommendations on specific health equity focused standards that could be considered in the PCPCH standard development process. So next slide, please. So the committee's work in general, as I already mentioned, is laid out in statute, is to advance value-based payment in primary care. And in the near term, we plan to look at aligning the collaborative's primary care payment reform work with that of the Sustainable Healthcare Cost Growth Target Implementation Committee. They have value-based payment principles, which include VBP targets, and there is activity right now occurring around getting mass kind of support for amongst payers and providers around this value-based payment compact that's based on the principles. And so if that moves forward, having the collaborative's primary care payment reform work aligned with this work of the healthcare cost growth target goals will be very important. And then also finalizing recommendations around incorporating health equity into the collaborative's work. So looking toward the future, just next quarter, our 2020 progress report will be coming, and we'll be submitting that to the board and the legislature. We also will kind of continue the current work that I already touched upon, and then we'll be focusing more intentionally on monitoring implementation of a voluntary behavioral health primary care integration payment model that collaborative members signed on to for 2020 implementation. Next slide, please. So with regard to the Health Policy Board support for this year, it would be really helpful to get the board support in connecting with other committees. I'm hearing a theme here, overlapping with the collaborative. So the Workforce Committee, Cost Growth Target Implementation Committee, and then also guidance on payment models that could sustainably support traditional health workers. And then looking forward to next year, assuming the value-based payment compact moves forward that I touched upon, looking at primary care specific payment models that will be in line with those targets. For example, the principles lay out a requirement around shared savings and shared risk models, or more sophisticated models. And so looking for guidance from the Health Policy Board on VBP models that could be adopted through the collaborative to align with those principles would be useful. So with that, next slide, happy to answer any questions or take feedback.
Thanks, Chris. Any questions or comments for Chris? Okay. Chris, thanks so much. And obviously, as was mentioned, there is this conversation about how does the board support cross-committee discussion. And I think that's something we'll definitely want to come back to later this afternoon. Before we take a 10-minute break, let me see if, and then we're going to come back, we're going to hear from Cost Growth Target, Healthcare Workforce, the MAC, the Medicaid Advisory Committee, and the HITAC. But anything folks want to call out just in the last couple of minutes before we take a 10-minute break? Anything that struck you across those 5 presentations that you want to flag for discussion later this afternoon? Okay. Still digesting, a lot of information, lots of good stuff. Let's take 10 minutes. Actually, we're going to come back at 2:55, so it's like 12 minutes. So please come back at 2:55. We'll get started right at that time talking about cost growth target. So thanks everybody, and we'll see you in 10. I saw John one moment ago. Okay. There's Ebony. Give Kirsten another minute or so. Okay, I do want us to get started since we have another 4 committees to hear from. So we're gonna go ahead, and I hope Kirsten will just join us when she's able. So we're gonna hear, I think, Sarah, are you here on behalf of Jack and Kevin? Okay, so we're gonna hear from Sarah Bartleman on cost growth target, and then we'll go into the other 3 before we have our larger discussion. So Sarah, take it away.
Thanks, Diana. Hi, everyone. Sarah Bartleman, OHA. I am lead staff for the Healthcare Cost Growth Target Program, and will pinch hit for Jack and Kevin, who both had conflict today. Jeremy, please feel free to jump in if you have any comments as we go through. And Kirsten as well, when you join us. Kirsten is our liaison for this work. So the Healthcare Cost Growth Target Program, the board has certainly heard a lot from us over the last year, also referred to as Senate Bill 889 or the 889 project. This came out of legislation in 2019, building on work from 2017, and really established the committee under the board, charged the implementation committee with developing recommendations for the Cost Growth Target Program, including setting the target, determining who would be in the program, and accountability measures. So couple of our highlights from the last year. We completed our, we completed our work at the end of January and submitted the final recommendations report to the legislature. You all saw this report and approved the recommendations at your January meeting. Thank you. And then our other big accomplishment for the year was really landing on the proposal and the recommended accountability mechanisms. So essentially what happens to a payer or a large provider organization if they exceed the cost growth target in a given year without a good reason. And so the committee really came together and had a tough conversation, both industry perspective and consumer perspectives, and found the right balance between something that would be effective as an accountability mechanism so that payers and providers will take this program seriously, but also that emphasize the transparency and collaborativeness of the intent of the program and not just jumping right to punitive measures. So landing on that accountability recommendation was a big win for the year. Next, our current work in January and February, that was getting those final recommendations in. We do have a bill in the legislative session right now, that's House Bill 2081, and that recommendation, or that bill, would be the authority to implement those accountability recommendations. So currently we're following that, seeing how that goes through session, and really starting to work on operationalizing some of those initial committee recommendations to implement the program. In terms of future work that the implementation committee will be picking up in 2021, initially we thought that the committee would be sunsetting at the end of 2020 when the recommendations were finished. We realized that we had another year legislatively to keep them around, and we asked them if they would continue, and they agreed. And so we are keeping them around for another year to dig into a couple of other things. That includes looking at some cost growth data and looking at drivers of what is happening with costs in Oregon, developing a strategy and a plan for monitoring for unintended consequences. This is something that we heard over and over again. We don't want to contain costs by hurting access or quality. And so we've bundled that together under a monitoring for unintended consequences umbrella. That will include both coordination and conversation with the Health Plan Quality Metrics Committee to identify quality measures for the program, and coordination with the Health Equity Committee to think about measures and an approach around equity and all of that and other unintended consequences. We also are going to spend some time continuing to develop our data use strategy. There's a lot of data in Oregon, and this will be what we're looking at in what priority order and how that will inform public reporting. We also hope that the implementation committee will spend some time this year developing guidance for performance improvement plans, which is one of the accountability mechanisms for payers and providers who might exceed the cost growth target. And then finally, recommending a future governance structure. So the committee will sunset at the end of 2021. We do believe that there should be another committee that comes in and takes its place during implementation or during full program operation. And there's some conversations to be had with the committee and with you all about what that looks like. In terms of where we are looking for OHP support and engagement, we intend to have some reports coming out looking at cost growth trends and price comparisons, that kind of thing, and we hope to bring that work to you in Q1 and Q2 for your review and information. We hope to have some iterative conversations with you as those proposals for monitoring for unintended consequences and quality and equity emerge, especially because that work spans all three committees. And then reviewing the charter for the new committee and figuring out that future governance structure. And then starting in 2022, we will begin having public hearings for the program, and we've talked before about the board playing a really key role in being the convener for that. Jeremy, anything I forgot?
No, I don't think so. I think the reason I think maybe we've talked about this in previous meetings, but the reason we really see a need for an ongoing committee beyond this initial couple of years is really a couple-fold. One, really being able to have the policy board who has a bit more arm's length distance from sort of the healthcare system, who's sort of running the public hearings and accountability piece, but but have a mechanism for more input from the healthcare system, and so a committee can serve that purpose of being able to provide that input, but still have the policy board still have a little bit of distance. Secondly, I think it'll be really helpful for us to be able to dive into where we really need to be tracking what's happening with costs in a given year. We expect there'll be sort of ongoing reports, but there's going to be reports that are going to be certain deep dives into a particular issue given what's happening, and so it'll give us an ability to help kind of hone in our focus in a given year. And then third, obviously, just be able to engage partners in the health system on ongoing program operations. So that's kind of where we landed on and why to have a committee that would continue on after this next year.
And I would finally just add, I believe we have space on tomorrow's agenda for a little bit more in-depth discussion about the board role relating to this program.
Thank you so much, Sarah, and thanks, Jeremy, for chiming in. So we are going to have a chunk of time tomorrow to talk about the board's work around the cost growth target, but I obviously want to see, and I know you've heard a lot from the committee, but just did want to see other comments, questions before we go to healthcare workforce. John.
Yeah, I just, as I listened to the comments, I recalled the meeting around accountability, which I listened to. And this was really a wonderful committee. It was an industry committee. This was a group of industry stakeholders. Consumers and patients were not represented, but it was a terrific committee, and they got their work done. And one of, I think, the most sophisticated members of the committee said, you'll know a lot when the deadline for the first submission of data comes up. Because for this to work, people are going to have to submit data and good data. And if they don't, they're going to have to be held accountable. So while it will take a while to, actually figure out what's going on in terms of cost and quality, we're going to know pretty quickly how well this is going to work. Most of the efforts that I think have preceded this, major portions of the delivery system, of the healthcare system, just never participated, just refused to send their data in. And again, remember, this is Medicare, Medicaid, and commercial, so it's everybody having to submit their data. So it's just a very interesting process.
Thanks, John. Okay, thank you so much, Sarah. We are going to move on to healthcare workforce, and I believe we have Mark Overbeck and Kurt Stilp presenting today.
Hi there. Thank you. All right. I appreciate the opportunity to be able to share with the board here this afternoon. I'm Kurt Stilp. I'm the chair of the Healthcare Workforce Committee. I'm joined by Mark Overbeck, our OHA staff to the committee. And the Healthcare Workforce Committee, as you may know, was established in 2009 through House Bill 2009, interestingly enough. It was the one of the two committees initially created in the bill, and our board liaison has been Brenda Johnson, and I want to acknowledge the just the strong support that we get from Brenda and the great communication that we get through Brenda to the board. The purpose of our committee really is to coordinate efforts to recruit and educate healthcare professionals and retain a quality workforce to meet the demand created by expansion in healthcare coverage, system transformation, and of course, increasingly diverse populations. I think we've certainly carried on that work. In 2012, we made recommendations for traditional healthcare workers. That same year, we made recommendations for the development of clinical practice standards. In 2013, we developed a strategic plan for the primary care workforce recruitment. And in 2014, we made recommendations, as you may recall, to the use of the Healthcare Provider Incentive Program. In 2020, of course, we did take a pause in terms of meeting due to COVID, so we did not meet our regular meetings in March and May, but we resumed activity in July, and we really came back looking at not only the Healthcare Provider Incentive Fund, which was the last time that we were before you presenting, was some recommendations regarding behavioral health expansion and programs related to behavioral health, but we really decided to really kind of focus in on reports that were really instrumental into understanding what the existing workforce looked like and then how we needed to potentially adapt moving forward. So we reviewed a healthcare provider incentive program evaluation, full evaluation front to back. And we really saw that increased awards helped keep up with increased costs of school tuition. We really saw that we were able to expand eligible provider types beyond just maybe some of the traditional healthcare providers that one would think of when it came to some of the programs. And then we were also able to support some of our racially and linguistically diverse folks who had gone through the healthcare provider incentive programs and then were now out working across the state. In January, just this last month, we also reviewed the healthcare workforce needs assessment that came with some recommendations. And as one would imagine, we need to improve diversity of our healthcare providers. That was a key thing from that assessment. We also need to increase or improve, I should say, the distribution of our workforce to more rural and underserved areas outside of the kind of population-centric areas of our state. But we also needed to address new healthcare delivery models, namely telehealth, as I think we all saw telehealth making an increase in utilization here over the last year with COVID. We also understood that we needed to improve data collection, and we also needed to increase the supply of some healthcare workers to areas where it might be harder to recruit some of the typical healthcare providers that one would think, so namely traditional healthcare workers and medical assistants, nursing assistants that provide a lot of the support for the providers that are out across the state. And then we also reviewed last fall and early winter, but in January we saw the full workforce diversity report, which is now published. And that really gave us a good look at our current workforce and highlighted specific areas where we needed to do better and where we could potentially focus some of our efforts. We also are fully able to do a webinar for any board member that might want to take a deeper dive on any of these issues. I know, I'm kind of just skimming the surface here, but we would absolutely be willing to host a webinar to dive a little bit deeper into any of those things. Next slide, please. So in terms of our current work, one of the things that we are primarily focusing on right now is a health equity framework and plan. We developed last year a health equity framework, which really provides the lens by which we are doing all of our work through. And so we kind of took a step back from that after we developed the health equity framework, and we asked the question, if we really do apply this lens, how does that change the work that we're doing? What kind of recommendations might come from applying that lens to, let's say, the healthcare provider incentive program or the like? And so we're moving forward now with engaging different voices to help inform this framework. And so as in preparation for that, several committee members are going to be going through a constructivist listening session where we actually learn how to engage in constructivist listening, so that when we engage in these listening engagements with some of our community partners here in April and May, we actually know how to do that in an informed way that will then, give us information that we need in order to make potential changes to the work that we're doing. In our March meeting coming up here in a couple weeks, we plan to engage the committee in that continued work for the health equity framework. We also want to expand to see if there are other topics for discussion that the committee wants to tackle in 2021 and beyond. And then, of course, here today we are open and interested to any direction or guidance that the board would want to give us in terms of informing this work or any future work. And then we will come back to you likely in the fall with proposals for an updated charter, as well as with some further recommendations for the healthcare provider incentive program. Next slide. I'm going to turn it over to Mark, who's going to talk about specific ways for the board to support our committee.
Great, thank you so much, Kurt. Good afternoon. The few pieces that I'm going to briefly touch on where we think the board support could be most useful begin with the composition of the committee itself. And we know that the membership of your committees is a topic of real importance to you. We are excited to come back possibly next month, maybe as late as April, with a proposed set of recommendations for both the reappointment of members whose terms technically ended in December of last year, as well as a very diverse, experienced, and highly intelligent set of new members to add their voice to the committee as we go forward, where that is going to be more important than ever. Later this year, as Kurt referenced, following the legislative session, we do plan to come back to the board with a set of recommendations around the distribution of funds that will be allocated to what we anticipate will be an expanded healthcare provider incentive fund. The governor's recommended budget proposes an additional $27.5 million in incentives for medical and behavioral health on top of the existing $17 million roughly. There are a number of legislative proposals that would add further to that. So we're planning on doing that work first as staff and then as a committee in a thoughtful process using an equity lens, and to bring that to you this fall. We're really hopeful that this set of recommendations we bring will be a set of creative and targeted investments that are consistent with the governor's budget and your desires for what the workforce in the future needs to look like. And then as we get out to next year, we're very likely going to come back to you as part of the next healthcare provider incentive program evaluation with some updates around the new strategies that have been developed, the legislative proposals out of the governor's budget, and to enter a dialogue of what are we seeing so far as we look at implementing new investments in career pathways, new investments, a more concentrated effort to ensure that the workforce of the state really does reflect the populations and communities that it's supposed to serve. That is really all I have. Kurt, thank you so much for doing a very thorough job. It's been really my privilege to be the lead staff for this committee for over 5 years now. And Kurt, thanks for inviting me to come present with you. And we are happy to hear any feedback from the board about what you'd like the Workforce Committee to tackle or any questions.
Thank you, Mark and Kurt. Comments, questions on workforce? Kirsten, please.
Hi, you all know my favorite topic on this. I'm a big fan of the Workforce Committee and super excited about some of the direction that you're talking about taking this. And I just wanted to add on the lens that I see this not only about how we as a state begin to provide culturally competent care or better dispersed care in our rural communities, but also how we, I think about income a lot as the greatest predictor of health. And so how do we use this to actually enable people to get living wage jobs and have break down some barriers that are in place to opportunities. So really excited about the work ahead for the Workforce Committee. Thank you.
Kirsten, thank you. I mean, in one way, it's so daunting, the work that's really ahead of us. And in another framework, it seems like it's such an opportunity to take a robust set of investments and really do the thinking and they're looking like, okay, we're going to venture out here now. So thank you, and thank you for your ongoing support of the committee.
Okay. Thank you so much. We're going to move on to the Medicaid Advisory Committee. We have Leslie Huggins and Jeremiah Rigsby, and we are going to be talking more later about the MAC and the 1115 waiver, so we'll have time for that as well. But want to turn it over to Leslie and Jeremiah.
Thank you very much. My name is Leslie Huggins. I'm a pediatric dentist who cares for high-risk and vulnerable children as well as special needs adults. And I'm co-chair along with Jeremiah Rigsby. And we are very thankful to be here today. And so let's go ahead and get started. The MAC, the requirement for the MAC was actually established back in 1965. And the relationship with the MAC and the OHPB, we formalized that via an update in our MAC charter just in 2020. So we're really excited about this opportunity. Some highlights of what the committee has done over the past couple of years. We produced a guidance document for CCOs where we looked at using health-related services to support housing needs, which we all know is a tremendous need. And then secondly, we generated a couple of letters of support. The first one was for to OHA Metrics and Scoring Committee. We're adopting the health equity metric for meaningful language access. And then the second letter, through some very interesting learned experiences, a letter of support to OHP Medicaid Director, where we advocating for prioritizing the resources required to decrease delays in newborn enrollment. And that was a fascinating discussion and journey to how we came to that letter. Now Jeremiah is going to take over and he's going to talk about the MAC's current and future work, and then also what we're looking for collaboration and support from OHPB. So Jeremiah.
Hello, everyone. I'm Jeremiah Rigsby. I'm the Chief of Staff at Care Oregon. Happy to be here and happy to have Leslie as a co-chair. The Medicaid Advisory Committee's journey over the last few years has been really interesting in that, you know, we really do want to support the agency in providing a bit of a consumer report. And I think, as all of you know, we spend a lot of time at this level talking about the high-level impact of what policy means on this population. And I think what we are starting to find out at this point is that the way that this impacts our members on the ground, the people we are actually trying to benefit with all of this decision making, is varied. And we really want to, A, represent the voice of those being impacted by the decisions we are making at different levels. But B, we also want to help the agency in figuring out what is or is not working when it comes to what sometimes can feel like ivory tower decision making, but also recognizing we have a community of stakeholders and people, whether it's in CCOs, whether it is you all, that are truly interested in making this program address what was the triple aim in CCO 1.0 and is now kind of the quadruple aim with providers. And I would just throw in, we're really happy to have such a diverse committee of people where we have folks that are familiar with the program from a policy perspective, CCO voices, provider voices, and they're very vocal and they very much want to be a part of this conversation. So connecting this work to the Oregon Health Policy Board to me is very exciting as well, just because it feels like this is the place we want to start having all of these different conversations about what we are doing in the state that looks like healthcare transformation. And we are focused on Medicaid, but we also have an eye towards how the other things kind of under the umbrella of healthcare transformation impact Medicaid and impact innovation. That being said, we feel like we have a lot of work to do to monitor CCO 2.0, right? You all are very familiar with how many things we talked about in CCO 2.0, how many policy recommendations there were. And it's been a few years, and we really want to see how this stuff is playing out with CCOs. What can we learn from some of the things that happened? And then what do we need to improve on, especially considering the fact that we know now it's not always super easy to get that community lens on how this stuff is working, right? To get that input into what's going right or what's going wrong within the nuances of managed Medicaid. We're excited about a subcommittee we started to improve consumer experience. That work began in January. We expect some consumer experience recommendations to come in the third quarter of this year. And again, recognizing everything from how our CACs, Community Advisory Councils, doing in CCOs, what's happening with the community voice there, to our meetings that we put together as a state accessible to consumers? How do we make sure that they can participate in a timely fashion that makes sense for them? In the future, we look forward to supporting the Oregon Health Authority, really continuing to support the Oregon Health Authority, and in connection, the Oregon Health Policy Board, with how we're developing the 1115 demonstration waiver. And again, as we talked about CCO 2.0, really how we're making sure we're elevating the voice of the consumer, making sure we're supporting the agency and gathering data about what is or is not working. And so that when we go through healthcare transformation in the future, it is well informed by what we have learned over the last couple of years. Next slide, Michelle, I think. Okay. Also going in the Q3, looking for a bit of feedback and discussion around some of the things we're talking about in the consumer experience subgroup. And then in 2022, looking further ahead, I think we hope to provide some feedback on what we saw regarding CCO 2.0, as I said, again, so that this body, the Oregon Health Policy Board, can have a bit of legwork we've done in advance to talk about what has or hasn't worked, and we're clear about what we do or don't want to fix moving forward.
Great. Let me see if there's, oh, David, please.
Yeah. Leslie, Jeremiah, thank you for sharing that. I really see your work monitoring CCO 2.0 as important, and I'll ask you to make just spend a minute to talk about how to make a connection between that work and the Medicaid waiver work, how they're connected. And let me just share my bias, which I disclosed earlier in the meeting, is that we had this really innovative approach in investing in social determinants of health. There wasn't a lot of granularity or specificity to that. We're looking at measures. Your committee was really important in making housing assistance available as an investment in social determinants of health. There's a lot more innovation, and with this focus on health equity, it seems like those two work plans are really intimately tied. How do we support that connection to inform the waiver work?
Well, Dr. Huggins, you want to go first? I have some thoughts.
No, go right ahead, Jeremiah.
Okay. Yeah, I think a few things. I think number one, the Oregon Health Policy Board, I really appreciate the overview that happened at the beginning of this meeting, talking about why the Oregon Health Policy Board was chartered and what the accomplishments have been. If you think about the things that could potentially go into a waiver, you're really talking about a wide spectrum of ideas. And in this state, you've got a lot of different places where those conversations are happening, right? Whether it's the legislature, whether it's a number of work groups that are coming back to this board. And what I think the Oregon Health Policy Board can do is to really add a global kind of framework. It's like, we understand there's many different parts of the state having these conversations about quote unquote transformation. With the support of the Oregon Health Authority, the Oregon Health Policy Board can really hopefully synthesize all these different pockets of work and say, here's what we feel like is happening that is good. Here is where we feel like there is an opportunity for success and improvement and innovation. We know, and Jeremy has led this for years, we know there's going to be a structured process for waiver development, including, public feedback. I think at some point we have to figure out how much, what's the size of the bite we're trying to take out of the apple when it comes to innovation, and how much of that happens within the waiver conversation. We're the Medicaid Advisory Committee, not the Health Transformation Committee, but you all, in my mind, are kind of the Health Transformation Committee, right? And so what parts of that are specific for Medicaid, and how can we help you? And then to me, what parts of this are a bigger conversation about transformation based on what you're seeing in the 889 group? I think John Santos is talking about the different levels that are there. And what role does Medicaid play in this whole spectrum of transformation? Those are really hard questions for us to answer, I think, just in the Medicaid Advisory Committee space. So where I see your role is helping inform us of how we can help in this bigger transformation picture.
Go ahead, John. Thanks, Jeremiah.
Yeah, gosh, I'm just thrilled that you all are interested in patient experience. You know, because of the HPQMC liaison work I do, as you probably know, there's this robust database of patient experience data by CCO that really nobody has looked at or kind of presented. And I would just love to hear more about what you're doing around patient experience, and especially if it includes some analysis of any of that data. And I would bet HPQMC would be very interested too. Good for you. Thanks so much.
And thanks for that feedback. It's a good place to look to. I think we've been kind of talking about just focusing on how the consumer interacts with their plan, with their CCO, you know, at a really high level, and not really what that means in clinical data. So they're both really interesting. I think fascinating.
Yeah, I mean, you know, it's survey data. It's the CAPS
Yeah.
data. It's the CAPS.
Right. It's right. But I mean, if you think about policy development for like the future of CCOs, how do you use what you've learned from consumers over the last 5 years to inform what you would want to make better? I think that's the question, right?
Great. Anything else before we move on? Jeremiah, Leslie, thank you so much. And now we have High Talk. We have Eric Doolin and Amy Henninger, who are going to be presenting on behalf of High Talk. And I'll turn it over to the two of you.
Great, thanks Diana, and thanks for having us today. I guess somebody gets to go last in the committee lineup. So here we are, the last one before you get to go to your further conversations. Just as a quick introduction, I'm Eric Doolin. I'm the chair of High Talk. I'm also the chief operating officer at Pacific Source, and I'll let Dr. Henninger introduce herself.
Yeah, hi, I'm Amy Henninger, Vice Chair of High Talk, and I am currently the Interim Medical Director for Multnomah County Health Department in our FQHC.
Thanks, Amy. So maybe just as a quick background, I think that all of you except maybe Ebony are still the same since last time we did a High Talk update, but just as a quick reminder, High Talk was created in 2009 by statute and then moved under the Oregon Health Policy Board in 2015. We are an 11-member council that's appointed by the Oregon Health Policy Board. And we've really focused on how do we endorse and support the adoption of electronic health records and electronic health information exchange. Our focus has been on working on the state's strategic plan for health information technology, having some level of oversight of the HIT work that goes on within the state, really doing an assessment and keeping track of what's going on both at a state and a federal level from a HIT policy standpoint, and trying to bring together stakeholders across the state to keep them informed of that work and also get their input on informing our strategic plan. Kirsten's been our liaison for, I don't know how long now, several years, I think. It's really been great to have her. It's been a good process. I think that's been helpful to have her input and be able to share what the priorities that all of you have with that work. So with that, I'll turn it over to Amy to talk a little bit about some of the committee highlights.
Yeah, thank you. So the main, we had two meetings in 2020, February pre-pandemic and then in August. The main focus for High Talk this year has been on the COVID health IT response, as well as some behavioral health IT technical assistance. In terms of the health IT response, High Talk had discussions as well as support, as did the OHA HIT group, around House Bill 4212, which is the Real D for COVID encounters. We learned a lot about what it will take for providers to collect Real D and how OHA can best support them. Hospitals, health systems, FQHCs are committed to addressing health inequities and need new resources, technology approaches, staff training, and operational workflows to engage our patients in collecting Real D effectively. We also learned that customizing EHR systems can be really difficult, and that smaller providers may lack the resources or leverage with their EHR vendors to make these changes for an Oregon state-specific standard. We learned from providers that approaching disability questions from a demographic lens is a cultural shift. We also understand there may be interest in expanding REAL-D data collection by providers. Given the experience with supporting House Bill 4212, it's become more clear that OHA may need to invest in a broader REAL-D repository and technology for REAL-D to capture data directly from patients, particularly for those systems that cannot incorporate it into their EHRs. We also worked on supporting COVID positive case data across providers through both the collective and the Reliance eHealth collaborative platforms. There is a bill currently in the legislative session, House Bill 3057, that would expand the ability to share COVID data with CCOs and health plans. In terms of behavioral health, HiTalk supported 2 learning collaboratives this past year. The first was peer-to-peer learning with 13 different speakers, almost 200 individuals, and 100 different organizations. Topics really around the EHR and HIE health information exchange utilization in Oregon. And then the second event was focused on privacy and confidentiality, specifically around data sharing and implications for updates to 42 CFR Part 2. Responses to these events were really positive, and we're looking forward to opportunities to support future learning collaboratives. So I'm going to turn it back to Eric to talk about committee work.
Yeah, great. Thanks, Amy. And so on the committee work, really going to talk just quickly about a couple different aspects of it, sort of what we've been working on currently and what lies ahead in future work. In the current work, we've been having some focus on community information exchange. That's really trying to help facilitate the flow of information between healthcare providers and some of the public health and social service providers. This work is really gaining momentum across the state with a variety of CCOs and health plans and health systems participating and really driving to get that community involvement to make that work successful. This really is a key, as we look at some of the work we're trying to do on social determinants of health, this community information exchange is really going to play a super important part in that. And we see this as this evolves over the next year, really being a key input and factor as we work on our updated strategic plan. The legislative session has a few different areas that we're focused on, just as that's going to influence the HIT work in the state. Amy mentioned the COVID data sharing bill. There's also some proposed legislation that would expand the REAL-D reporting from providers. That obviously plays into a lot of the health equity work. There's also some legislation that would require some OHA to establish some work groups to look at the health information exchange and the community information exchange I talked about earlier. So we'll see where that goes. And there's also a few different things in the telehealth and prior authorization arena that could impact our work as well. So quite a few things going on in the legislature that we'll see at a state level impacting our work. At a federal level, hopefully many of you are aware of the interoperability rules that are out, and people are busy working to implement a lot of those requirements take effect later this year and into subsequent years. HiTalk and OHA have really been engaging stakeholders to help build an understanding of that. There's been a series of webinars just to help educate people on what those rules are and what the implications are. And that really creates a new set of requirements that allows patients to access their information more easily and for information to be shared across organizations. And so there's a bunch of work going on there. This is another area that we see as having a fairly significant impact as we look to update our strategic plan for next year. In terms of future work that we do have going on, we have lost a few members on HiTalk, so we are working to try, the Office of Health IT is working with the OHPB staff to try and identify some additional members. We will be coming back to the Health Policy Board probably in the summer time frame to get approval for additional members. We've had a few people leave the area or change jobs, so they're no longer with us. We've had some discussions about sort of what are the targets of skills and capabilities and backgrounds that we would like to add to High Talk to really maintain that broad community-based and depth of experience across technology and different provider types and a variety of things. So we'll come back with some recommendations on that, and hopefully some new members to join us. And then we're really going to restart our strategic planning work. We started that last year, and because of COVID had to put it on hold. We weren't able to meet and didn't want to continue that work. And instead of sort of picking up where we left off, we're basically going to try and start over. There's been so much change that's been impacted by COVID, as well as other things going on across the state and the country, that we really felt like it was time to start back and kind of start from the beginning on that strategic plan work. And so that's where, that's really where the big part of our focus will be this year. We'll continue to work on driving EHR adoption and trying to spread health information exchange. We'll be looking at how health IT can support the new models of payment and the value-based payments that we have requirements for, trying to make it easier for patients to get access to their own data and make that available to their providers. And all of this work will really have a strong focus on social determinants of health as well as health equity. And so that's really where we're going to be focused over the next year. In terms of the, what do we need from you, really looking to get that support for the additional membership. We would anticipate coming in the first part of 2022 to get approval for a strategic plan, kind of on that cycle that we would have planned to be doing right now if things had played out normally. And that's really, and I guess the last thing is just if there's any updates or priorities you had on the strategic plan or any changes of things that from your priorities, that would be helpful here as well. So questions before we wrap up?
Thank you, Eric. Thank you, Amy. Go ahead, Brenda, and then I think John may have a question. I'm not sure. Go ahead, Brenda.
Thank you so much for the work, Eric and Amy. I'm curious to what extent our committee here is also scoping issues of broadband width in rural communities across the state. Of course, COVID and telehealth visits have really, brought it, that issue, I think, into greater light, and I'm curious to what extent you're looking at it.
Yeah, we have not spent a ton of time in that specific area, but I think that you're completely right that a lot of the the demand for telehealth has really highlighted some of those challenges. And I anticipate that one of the things we have talked about is just the need to make sure we're thinking about telehealth and what can we do to support that. So I think that as we look to that strategic plan, that broadband access will be an important part of that consideration.
Thanks, Eric.
Oscar,
please.
Yeah, maybe like also a follow-up to the conversation around telehealth. One of the things we've heard from last year from some of our community presentations were about just, the challenges that telehealth created, particularly for communities of color, and then also communities who had access to challenges with technology or language barriers, especially as it relates to like the workforce. So it's sort of like all interconnected, and like some of all this work is interconnected. So just curious if is High Talk currently sort of interfacing with the other committees as you're approaching your work?
Amy, do you want to take a first part of that one?
I mean, we met once since COVID, and that was in August. We definitely started to have some conversations around telehealth. I think it's part of the reason why we need to relook at the strategic plan, because that wasn't even much on our radar last year. So I think that's work to do. And I think looking at the work that's happening on other committees is a really important piece.
I think that's been part of the consistent theme, just listening to all 9 of the committees today, is sort of how can we interconnect and make some of those connections. And maybe that's some of the discussion all of you will have with the rest of your retreat, I imagine. We've had, not necessarily with interactions with the other committees, but I know that we've had people from the various offices that support the committees from the OHA came. We've heard from health equity, for example. We've heard from public health this year. We've heard from several others that I'm not recalling. So I think that we've tried to stay plugged into some of that, and there's probably opportunity to do more of that in the future.
Great. Anybody else? John, please.
Yeah, Eric, I would just so identify with your point about small and medium-sized groups have just no power with their vendor. And that's going to be a big issue eventually, trying to get everybody on the same page. And as long as folks are still in those small and medium-sized groups, those vendors are going to do virtually nothing for them. The business model just doesn't work.
Yeah, I think that's true. I mean, and I think the other thing that's important for us to recognize too is that even in cases where Oregon does things that differ from a national standard, we face challenges. You know, when we've tried to do some things where Oregon's picking their own way of doing it, even getting an Epic, you know, that has a huge presence in Oregon is challenging. So I think to the extent that we can stick to national standards and really leverage things that exist and don't try and create things in our own backyard, it's really going to simplify things from a vendor and an HIT standpoint. I really agree with your thought there, John.
Okay, Eric, Amy, thank you so much. Really appreciate it.
Thanks for having us.
Thanks for having us.
That concludes our presentations from all of the committees. So a couple things, shake, stand up, roll your head, whatever you need to do to just take a breath, because we still have more to talk about, but just want to give people a moment to stretch, do whatever you need to do. We're not taking a break, twist, all those good things they tell us to do when we've been sitting for way too long. Wanted to sort of, wow, that was a lot. And that there is a depth of work there and a comprehensiveness of work there that is amazing and very impressive and a lot to digest. What we hope to do in this next, and I do need to say, Ebony had to join us by phone because she's in transit. So she is still with us, but she's on the phone. So she wanted me to let folks know that. So wanted to sort of take a breath and step back and think about the board's role vis-a-vis the committees, given all that you've just heard and the conversation we've had. And so wanted to just take a moment to just sort of talk about that liaison role again. So just sort of refresh that piece, but also the question, the conversation we want you all to have is, you know, we want to talk about the liaison role. The committee work is more than that. And the question we want to sort of ponder with all of you is sort of what is the most useful and effective way for you all to think about and approach this work? And, you know, how can the board best manage supporting and engaging with your committees? And what would you want to see different, or what would you want to do differently, or what are some of your ideas? I mean, we've certainly heard a lot about the importance of cross-pollination today, and, you know, want to hear from you about that. So that's where we want to spend the rest of pretty much the rest of our time today, is hearing for you all to have a conversation about, given all that you've just heard, you know, what are the big issues that came up for you? And what are your thoughts on effectively moving forward? Before we jump in there, I did just want to, we sent out a revised liaison role. It was, I believe, it's 4.0 in your packet for today. And there's a list of committees there, but then we did make some changes to staff, made changes based on some of, based on your feedback at those pre-retreat discussions, and just wanted to, so we had this whole, you know, what the liaison should do and what the committees should do. And so we did want to see if you had any, before we get into the meaty conversation around sort of, and this is part of it, obviously, how to best support and engage the committees. What are folks' thoughts? Do you have additional input or reactions to the liaison role that you wanted to share with your fellow board members? John, please.
Yeah, I think overall it's fine. I did chuckle about the part is that the liaison should not influence the committee. As I think you all recall, HPQMC voted no on the equity measure. First time it came through. And there were many discussions at OHPB about, what do you mean they said no? How could they have said no? And I remember Carla was the chair, coming over to me and at one point saying, you got to just get over there and tell them to say yes. And I said, I don't know if they'll listen to me, you know? And she said, you mean do I have to come and tell them that? And she did schedule herself to come. But then Trilby, I think she had weather problems or something like that, and she couldn't show up. So Trilby and I tried to carry that message to them. You know, you can't just say no. If there's a problem, you got to figure it out. We want an equity measure.
Mm-hmm. Mm-hmm. So John, can I just clarify the section you're talking about? Because in the liaison description, it says the liaison role is to listen, support, and influence committees, not drive decisions and direction. And so I think that may be a distinction between what the liaison role does versus the committee as a whole, if that makes sense.
Maybe. It just made me recall that very difficult time when, you know, they had methodological issues. And so it offended their research and science sensitivities. And we had, you know, social and emotional issues. And so yeah, I guess that's right. To some degree, the liaison can come and say, well, I'm just here to tell you the whole OHPB thinks this is what you need to do, not me. You know,
let me distinguish, because this came out of a pre-retreat discussion, which was, I think that there was a sense, and I'll let other board members speak to it throughout, that the OHPB member maybe shouldn't have an undue influence. You know, that you still want this whole committee process. So I think that, and maybe we captured it clumsily, but I think that was the thought there. Mm-hmm. Brenda, go ahead, and then Trilby.
Yeah, I think I generated that comment sort of in reflection of my own role and responsibility in supporting the Healthcare Workforce Committee. I love that work very much, and I recognize that if I'm not careful, conversations may sway over things that I say. Just and I'm a contributor, but I really acknowledge the wisdom that is in the group, and we have diverse committees for a reason. So it was mainly in the spirit of that. I think, John, to your point, as the board ought to have like absolute comfort in sending things back to committee for further development. Again, as my liaison role in healthcare workforce, this board did that for me, you know, and said, actually, we're not ready to approve the healthcare provider incentive program unless there's some dedicated resources in behavioral health. And I was the message bearer for that and recognized absolutely the board was dead on for that reevaluation. So it's mostly, I think, about channeling the communication between one body to the next. Yeah, and this document for me does a lot of clarification for that purpose.
Yeah, I don't need to comment further, Diana. I think Brenda really captured it, the distinction there. John, you and I were carrying a message from the full board, much in the way that occurred with the Healthcare Workforce Committee on that one occasion. And we did then find out ways in which we could support them further. We brought in a consultant to work with them, and so that I believe that ended up in a good place.
Any other comments on the liaison role specifically?
Just, you know, as a board member new to this board several years ago, I don't think we had really emerged in the role and responsibility of a liaison, and I wasn't necessarily recruited with this expectation in mind. And as it's developed, and as I'm thinking about recruiting new board members, I want to make sure that we're clear among ourselves about what the expectations are, what time commitment we're asking of one another. You know, is the idea that every single board member also has a liaison responsibility? If not one, what do we do if there's more liaison coverage that we want to create? And so how do we as a board create agreements around those kind of topics so that those expectations are clearer? I don't know, Diana, if that's part of the agenda for today or the time to kind of anchor.
I think, yes, I think this is the time for the conversation, Brenda, absolutely.
Yeah. And then second to it, just based, I would step back again and look at the structure of the committees and recognize, as was shared, you know, throughout today, that some committees naturally align with one another or are nested. And I think about the patient-centered primary care home and value-based payment work connected to the cost, you know, growth target work. And I think about how HITAC and health plan quality and metrics and scoring all have a life together. And so curious about our structure as liaisons, if we support a grouping or if we support or there are subcommittees of one another and we actually recalibrate the structures themselves so that we know what our coverage actually looks like. Yeah, 2 comments, 2 thoughts.
So let's start with that first one about the expectation, or is there an expectation? And I know that came up in the pre-retreat sessions about, you know, if there is an expectation, we need to tell people as they are recruited. And so I guess I'd ask board members, is there an expectation that each board member is a liaison to at least one group? Or do you do something different for the chair and the co-chair? Or what is the, you know, what do you all think from a board perspective?
Yeah, I'd advocate for yes and yes. Yes, there is an expectation that every board member serve on at least one liaison committee role. And that I'd like to keep our board chair and vice sort of outside of that loop. And the only reason for that is they are already super busy with OHA leadership, convening the board development work, you know, meeting frequently about our agendas and what the work is in front of us. So I don't know, David and Oscar, if it's fair to, you know, take you off the hook, so to speak, but I think that there's a part of it as we bring on new board members that it's probably only fair to say, if we agree today that yes, that's an expectation, then we may even recruit for that purpose, right? We might see a committee that actually needs some heavy lifting and say to ourselves, how do we actually narrow our recruitment focus to really engage where that need is best lifted or best placed?
Yeah, no, I thank you, Brenda. I appreciate sort of giving us a freebie, because I think I'm one of the few board members that's not currently tied to a committee, and I think it would be, you know, I think I could do one or the other. I don't think I could commit to both. You know, if the group decided that having a liaison connected to a committee was really important, I would be totally on board with joining a committee. Though I don't think I could do, you know, both be in the vice chair role and in a committee role. There was also something else I wanted to say to that. Oh, yes, I really liked your idea about almost recruiting the last few board members, specifically to the committees that we can't have a liaison for, or that we're missing a liaison for. And I think in the past, you know, I really like the idea of actually bringing up board members from the committees themselves, right? They would just bring so much knowledge already about the work that is happening. That's why, you know, having committees that are diverse and representative of the community that we're serving is so important. So I'm really happy to hear that folks are kind of elevating that and paying really close attention to that as we move forward with adopting new slates.
Please, Kirsten.
I agree with what has already been said. I also want to caution a little bit that we don't become kind of single issued board members, because I think in thinking about the kind of synergy that we want to see between our committees, we want to see that between us too. And so maybe some switching it around after some appropriate number of time, I think would help with that.
Great. David, John, Ebony, thoughts about making this expectation. This is a clear expectation. You're on the board, you serve as a liaison unless you were chair or vice chair, and then it's optional or whatever. David?
Yeah, I support that. I think, you know, for me, it's a little bit different. That is, public health is my day job, so it's all this work is the same work. So it's not actually necessarily more work. This discussion, however, has really brought up a new framing for the liaison work for me, because when we were doing CCO 2.0, it was like keeping communication between FAB, social determinants of health, local health authorities, part of the CCO 2.0 framework. So it was this bilateral exchange of information. When we're with a focus on health equity, what I've seen today is there's so much more importance on talk between subcommittees. And that's more complicated than just communication between the board and the subcommittees. And I think we need to maybe later in the discussion struggle with that a bit, because you know, we had a bit of an experiment with that when Oscar was in contact with Health Equity Committee, and we talked with them. I saw the work was parallel with the FAB. We tried to arrange that crosstalk, and it was a little bit, you know, getting on agendas a little bit cumbersome, and we were a little, you know, I think we could have done that better in retrospect. But that's matrix organization, and matrix type communication is just it's much more complicated, but also much more important with the health equity focus going forward. So we should come to terms with that.
We're gonna definitely, we're gonna talk about that for sure. Ebony, please.
Yeah, and I was just, can you guys hear me okay? Hello?
Yes, we can, yes.
Okay, cool, sorry. So yeah, so I totally agree, and I think it's important, you know, that everyone, you know, holds their piece of the puzzle, and, you know, being new to this board, there is definitely a lot of moving parts. Thus, it's crucial that, you know, we finish recruiting so we can get additional folks to be able to kind of, you know, help provide the necessary kind of interface and oversight and engagement. You know, but I think for me, one of the things I've just kind of been echoing throughout and thinking about is just, you know, how do you make it digestible and feasible, you know, to the point that it's not overwhelming to the point where it becomes, you know, impossible to track or bring forth some meaningful kind of recommendations or input because you're just busy trying to chase everything to track everything, you know? So, you know, for me, you know, and doing this role, I'm just trying to figure out, you know, so what's my little strategy going to be for kind of, you know, just tracking so that then I can, you know, not only be up to speed and informed, then, you know, provide, you know, some value around perspective and input, if that makes sense.
That does make sense. And I think it almost goes to the second conversation, which we're going to have, is around the grouping. Or is there, you know, is there a way to be creative, for you all to be creative to sort of make sure those committees have a connection to the board, but not overtax your board members, because then maybe you won't have any, then you'll have a harder time recruiting, right? So how do you so I want to, I think the only person I haven't heard directly from on this is John, whether you would be in favor of making that that is an expectation of being on the board, is that you participate as a liaison, and if you're chair or vice chair, that may be optional. So I think that's what's on the table, and I just want to see, I think, John, you're the only one I haven't heard from.
Yeah, I agree with that. All I would add is agree with Ebony. We need more board members.
Yeah.
Because I do think it makes a difference for a board member to be a liaison and to actually have some, you know, intense interaction with that subject area.
Yep. Okay. So it's, I don't know that you all need to take a vote on this or anything, but that it's, that would, I don't know if you need to take a vote, do you? Or is it just, is it, David, anybody, thoughts? Or it just becomes part of the liaison expectations of the board? Steph, do we need to vote on it?
I think we should,
No.
are there any concerns about this approach that we should hear, make sure that we create a space for that?
Any concerns other than those that have been articulated about making sure this is manageable?
I think we may also want to just, you know, as we're thinking about recruitment, and we're also already talking about how it can be a little bit challenging to recruit. And then this, we may just want to sort of also allow for like a little bit of a grace period, right? And as we onboard people, as folks are being onboarded to the board, kind of let them sort of have a certain amount of time to get their feet under them, and also start moving them in the direction of a committee as well. Because it can take it can take some time for folks who are not like in, you know, living this type of work all the time.
It's a great point. So you don't have to attend a board meeting on day one and a committee meeting on day two, right? That you actually have some time to, and I think Ebony described her recent experience with orientation, which was great, and it was a lot, right? That onboarding was intense and important. Okay, so I think that you all are clear that you would like to have that be part of the expectation, and that expectation be clearly communicated, both during the recruitment process as well as when folks are become members, right? The second thing I wanted to come to before we get more into this chunk is the second issue Brenda raised, which was around, is there, and Brenda, I'm wondering if you would just talk a little bit more about what you were saying. You were talking about, does it make sense to sort of group to group committees together? And can you just talk a little bit more about that and any thoughts you have on that?
Yeah, I'm just thinking about the tighter alignment that we heard throughout today and how some of the work and overlap could be structurally designed, you know, to ensure that our liaison functions and the committees themselves are nested. So using metrics and scoring and the Health Plan Quality Metrics Committee as two obvious examples where, you know, on one diagram we have them as separate and both reporting to OHPB, and yet we know that metrics and scoring is a subcommittee of health plan quality. So there's a little bit about real estate and sort of the visual connections. And again, I mentioned that about primary care payment reform collaborative and how it naturally links to the total cost of care work. You know, there's arguments that we could say if we were to remap and design this from scratch, what might be the ideal situation? And then thinking specifically about, you know, the governor's letter and our work for the next year, 2 years especially, and where the heavy lifts in our committee structure are going to be most targeted. I don't know if that gave you the background.
No, yeah. No, I think that's fine. I think that's great food for thought, and would be interested in board member consideration or discussion of that. Oh, Kirsten, you're on mute.
I was just giving an affirmative.
Got it. John.
Yeah, just a side comment. You know, that dotted line, metrics and scoring to HPQMC, believe me, to the metrics and scoring committee, they consider that a dotted line. I think they would claim, you know, we're instigating a constitutional crisis if we disagreed with the decision they made about the incentives and said, you know, we want more measures or we want these measures. My impression is in statute, they are independent. And they make, those 9 people make the decision about that $200 million. So that's just a side. as I listen, there are some issues that cut across multiple committees. I think the most challenging one is going to be measuring equity. How will we do that? And there are just multiple challenges with it. I think, you know, the primary care doctors, when you talk about equity somehow coming into primary care, obviously the equity committee cares, HPQMC cares, metrics and scoring cares, 889 cares. So, you know, I just think trying to figure that out, because I think that's one of the first things on the horizon to do. How can we measure this? You know, we took a somewhat of a easy way out going with the interpreters. But that's not ultimately what needs to be done to measure equity. So that's one thing to think about as a tie that really ties multiple of these groups together.
Diana, I have a thought to throw out to the board members to see, because I think what John's comment is so interesting, especially if you kind of crosswalk it with this nesting concept that Brenda's raised, and you think about how the challenges around equity and really the direction around prioritizing equity, which this board has given to the committees, how's that playing out for these individual committees? It really is kind of fascinating. Brenda, I think you mentioned nesting HPQMC, metrics and scoring, and HITALK. And John, the thing that they mentioned in the HITALK presentation was, what about a patient portal for RealD? You know, what about creating some kind of different ideas for gathering some of this RealD data, without which we really can't measure our progress? And so in ways, there is a relationship there between those three committees that might help, if they were to work more closely together, might help them confront some of these challenges. And if we had a liaison covering all three, maybe that would help with the cross-pollination. Of course, it would be a tremendous amount of work, so there's that. But the nesting idea is really fascinating.
David and Kirsten.
It's more than just those three committees. And that we heard, and John, I endorse your point completely, that it's really nice to see us move from access to language services, which is an important process measure, to more of an outcome measure related to health equity. We really have to do that. And also we need RealD data to do that. And it's really nice to hear from metrics and scoring that they're looking at social determinants of health, and equity is a social determinant of health issue. Those are the same thing, you know, slightly with different words and different frames. And that's the priority for metrics and scoring going forward. I'm thrilled to hear that, as I said, but that also touches on Health Equity Committee and Public Health Advisory Board and all the committees we heard from today. So it's a nesting, but it's not just three committees, there's actually several committees. And I don't know if there's a linear connection or some other type of matrix connection, but I think that's for us to figure out in this discussion. I think Jeremiah said it well. You know, our job as Oregon Health Policy Board, especially with the governor's charge, is to synthesize these pockets of work. And I think it's really is going to require the synthesis in innovative and creative ways. I don't know exactly what that looks like in terms of organizational structure. I know it's administratively complicated. It takes more time. It's hard to get things on the agendas and sequence the agendas of these subcommittees because they meet every month or 2 months. But I think that's really a high priority for us going forward, is to create that synthesis that Jeremiah referred to.
Kirsten.
I think that we are that. We have to do the synthesis, and we are the tie between all the committees. So as daunting as that is, that is us. And so how do we do that? And my mind went to staff and how much cross-pollination or coordination between these committee staffs in OHA exist currently.
Do we Is there any mechanism, I guess part of the question I think is, is there any mechanism at this time to have staff cross, any formal mechanism, and whether it be staff or chairs? So staff or something, Trilby, or any thoughts?
I was gonna ask Steph if she could comment on that. There is a regular meeting of all the committee staff. I think it's monthly.
We can't hear you, Steph.
Sorry, I was room hopping.
Looked like you were walking through the forest. It was lovely.
How nice wouldn't that be? Yeah, so we currently have all the committee staff of the board, as well as some other committees like the HERC. I'm trying to think of a couple others who all of our staff meet monthly. This group has mainly been, the function of it has been to just update other staff to let them know what people are working on, potential opportunities for alignment and coordination. Sorry. And then also we've been working on some shared processes and understanding. So I think one of the things that we learned in some of the pre-retreat meetings is that for example, all the different liaison roles have actually shown up quite differently in the committees, and that we, even as staff, unintentionally often use our liaisons differently or engage them differently. And those are the kinds of things that we're working to address and standardize. But I think what we're learning here is that there's a lot of room for improvement, and you know, the committee work is usually often only part of what our staff's role and job is, but I think there's more work to be done on alignment there.
Please, Kirsten.
I don't know, at the risk of this spinning into something entirely undigestible, I'm like, we take our board priorities and we focus on those to say, here's our North Stars. How are these represented in each committee? And so like, we're not like looking for an unlimited amount of possibilities to overlap, but we are saying on these three issues, let's come together.
Great, Brenda.
I think building off of that, Kirsten, but from a committee-led perspective, I would offer that perhaps the committees could inform this board and sort of help us gaze into the future around the work plans that we have in front of us. So we saw it kind of in segments today, Q1, Q2, Q3 in next year, or this year, next year, that we as a board approve that work, so to speak. You know, we see it kind of from one fell swoop. And again, not to make it overly indigestible, but to think about it from that vantage point, then we will also be looking for the crosswalks while our staff and OHA are looking for it as well. Yeah.
Additional thoughts about this? So really focusing on, and it is an overlap with the liaison role discussion, but how does the board, and this goes to this question, how does the board best support the committees, engage the committees, help the committees do have the committees help the board achieve those North Stars, as folks are saying. And so one idea here, or at least and this came up in some of the pre-retreat discussion too, which is elevating those priorities. So I hear two things. One is, how do you crosswalk across these committees to sort of elevate and make progress on those priorities, number one. Number two, I hear Brenda, you talking about, we should look, and I think my guess is staff is already doing this, like what are the things in quarter 2, quarter 3, quarter 4, and looking at those together, and not only seeing where there might already be connections, but ensuring there are connections. Does that make sense? Is that reflective?
I think one of the things I'm kind of like hearing that I think we might want to consider looking into is we may need like a global charter, like, sort of like a global committee charter that all of the committees are under. because I think each committee has created its own charter and they have their own like plans and, you know, they're doing this thing, but we don't have something that we're sort of saying, okay, all committees, here are the 3 expectations that we really want out of all of these committees. So I think it might be interesting. I really like the grouping idea as well, Brenda. I also see a lot of like potential grouping between the FAB and the health equity and potentially even the workforce committee. One of the things that I'm thinking about, you know, unintended consequences that could occur from this conversation and sort of saying, oh, collaboration between all the committees, is that I'm a little bit worried that the health equity committee could then all of a sudden like be overwhelmed by every other single committee being like, look at my stuff, does it meet like your health equity sort of requirement, right? So I'm a little bit nervous around that. I don't think we're anywhere near this point yet, but in the future, I would love to be at a point where we don't need a health equity committee, right? I would love to be at a point where each and every single committee has a health equity lens and a health equity perspective, and they can understand health equity. So we don't need to have this other separate committee where everybody goes to.
And Oscar, let me just emphasize that point in terms of the challenge of that, because in our little, us bringing FAB and Health Equity Committee together, you know, that process took, and bringing it to the Oregon Health Policy Board, that took about, 3 months. And that was just 2 committees coming to, you know, talking with each other and then agreeing how they were going to co-present to the board. And that was a long turnaround time, and there's a lot of work on basis of staff. So, you know, we probably need to think about other mechanisms, maybe a health equity summit where, I mean, I think that the discussion today was very efficient, that every committee heard from every committee, hopefully, and heard the crosstalk and the opportunities and the synergies. And that might be a more efficient way to use everybody's time to create a common understanding and body of work.
Ebony, and then Brenda.
No, and I appreciate, Oscar, what you brought forward, because it's really, how is there a kind of, like you said, how is there a global equity lens that folks use to carry out their work and to make, you know, decisions and to track, you know, outcomes, metrics, so on and so forth, you know. And I think it's you know, each committee is unique and is individual. And so, you know, rather than having kind of this scripted, like, you will meet with the equity, you know, you know, this many times per year, it's broad, where it's like, you know, it's based on the unique focus and priority. But, you know, I totally agree with, I mean, because we're also at that point where, you know, it's the responsibility of each group, each individual area, to be able to, you know, integrate and move forward the equity, priority, and value without, you know, technically having to have somebody hold your hand or their hand, or put the work off on a committee, which just then adds to their administrative burden. So.
Great. Brenda, go ahead. Thanks, Ebony. Go ahead, Brenda.
I just wanted to remind us all not to underestimate the power of our chairs. You know, our committee chairs, as we heard today, they're really incredible humans. And I'm thinking about them connecting with one another and bridging that, you know, committee to committee work, alignment of the conversations, you know, fueling synergies that they then can take into the committee work with staff. So I know many of them are still on the call. I don't know if it's fair to ask them to speak to this conversation because they're living it. Just thought I'd throw that out there.
I think oh, John, did you have something?
Just following Brenda's comments, you know, you also have some ex-chairs that are an incredible resource. I mean, Will Brake chaired metrics and scoring from its inception to when he left a year or so ago and was replaced by Amit. He's an incredible resource. The 2 initial co-chairs of HPQMC, Sean Parkman is still around. I'm forgetting the name of the wonderful doctor from Hood River, who actually left to do a policy fellowship in DC. Maybe she's come back. So the ex-chairs of some of these groups are an incredible resource.
Let me, other comments before I summarize this piece where I think what I hear from folks. So it sounds like you all are in strong agreement that there has to be more intentionality in this cross-committee work. And there are a number of different mechanisms you could use to do that, ranging from the staff meeting that happens, sort of being more, sort of thinking through what that would look like, to maybe having committee chairs meet quarterly or something like that. Like, you know, I'm making that up, but and not or, right? So you can have the staff piece, the committee piece, the chair piece, and thinking through some of the how do you see the work holistically? Because as Kirsten said, like you guys are, and David, and we're like, you are the synthesizer and the hub. So how do we use all of that to sort of surface it to the board so that you all can hold that? What are the mechanisms to help you hold that? And then I want to call out this you know, not wanting to, I think Oscar's point is really important, like not wanting all of a sudden the heck to have 8 committees coming to it saying, you know, we have to work with you now. We want, you know, we need to work together now. And how do you sort of make sure that's everybody's responsibility, right? To Oscar's point, that equity is all of the committee's responsibilities. And how do you make sure there is that global lens? While also making sure there's cross-pollination. So I think that's sort of where we are. And what I wonder, I'll just put this out there, what I wonder if it would make sense for staff to come back with a proposal or a couple of options, and that you guys can have further discussion. Because part of this, and I should have said this when we started at 1 o'clock, is what's going to get teed up for March, right? There's going to be work here, the discussion that you have here, and then what is the follow-up piece in March? So that's an idea for next steps, and I want to hear a concrete next step on this piece, and I want to hear from folks about their thoughts on that. Yes, no, maybe an addendum, better idea. I mean, if you guys want to come up with it right now, we could do that too. But what do you think in terms of a next step to realize what you all have been talking about?
Does staff have what they need to do that?
I think we can take this information and synthesize it, and we'll see if we hit the mark. I think we're always happy to try that.
And, you know, kind of going back to Brenda's point too about, you know, there's potential committee chairs in the room. There's also OHA staff and leadership. I'd be curious to hear, you know, their thoughts around this conversation, because it's a partnership between the board and the staff, not just like, here's what the board wants.
So let's do 2 things, Oscar, so appreciate that. So let's ask that first question, and then to go to Brenda's earlier question, I think if there are still chairs and staff in the room, we can ask that. So and Jeremiah just volunteered himself by putting his camera on. But let me just take let's start with hearing from some committee chairs, and then we can go to OHA. So Jeremiah, do you want to sort of chime in on this, share some perspective? And I invite other chairs, or if you know your chair isn't here and you're on a committee and you really want to weigh in on this, would love to hear that. So Jeremiah, go ahead.
Yeah, so thank you all for opening it back up to us. Full disclosure, I've been thinking about this a fair amount, having gone through, you know, CCO 2.0 and watching OHPB over the years, and watching the Medicaid Advisory Committee over the years, and also watching how hard it is to get transformative stuff through the legislature, because they have negative -5 minutes to discuss anything, and the stuff is really complicated. And so, and obviously the legislature is also vulnerable to multiple opinions with not a lot of time to consider those opinions. And so I think a couple of things, I've been looking a little bit at the statutes around the Oregon Health Policy Board, and I think there's a really good reason for there being, you guys are talking about recruitment, and I think it's good to limit the amount of people that are benefiting financially from the healthcare industry on the Oregon Health Policy Board, because you want the board to be representative of the community. You want there to be some healthcare expertise. But then I think if you keep those caps kind of in place, which arguably makes sense, then you do want to figure out the right way, and I'm biased here, but you do want to figure out the right way to take advantage of who you have chairing these committees and how they participate in the bigger conversation around transformation. I don't want to ignore the fact that adding more people doesn't mean your agenda gets streamlined or that people won't have agendas of their own. Like, that's its own issue. But if you recognize, I think academically, how the Oregon Health Policy Board was meant to be set up, limiting the involvement of the healthcare industry, but really you're asking the Oregon Health Policy Board to be a North Star for healthcare transformation. How do you do both of those things? And that might be around, and I say this as a person who's been on the Medicaid Advisory Committee for a bit and will be phasing out soon. You might do that by figuring out the right mechanism to involve chairs in different parts of these conversations in a more routine way. And the last thing I would say is, I think, and I'm biased here, but I think it would also benefit the Oregon Health Policy Board to think about how the legislature is involved. I think there's not, if you think from a personnel perspective of the big names in healthcare policy development over the last years are not around. Mitch Greenleaf's not around anymore. And Alan Bates is not around. You have some young legislators that are starting to do really great work and on both sides of the aisle and in both chambers. But I do want, they don't have the decades of experience in the legislature to really build on. The people that really started, the Oregon Health Plan, they're not really in office or around as much. And so how do you kind of train up the next group of legislators to get in the weeds on issues where you really don't have time in 5 or 10 minutes of committee hearing, to do that? And again, not saying that'll be rainbows and butterflies, and there's a whole host of issues, but those are just a few thoughts.
Thank you so much, Jeremiah. Other committee chairs or representatives who'd like to sort of share their perspective on what the board's been talking about?
This is Leanne Johnson, Equity and Inclusion Division Director, and the Health Equity Committee chairs, I think, have left. And if there's no other chairs that want to speak from other committees, I'm happy to jump in, but I'll wait.
No, Leanne, please go ahead.
Okay, well, thank you. I've appreciated the conversation, and I'm going to jump in and talk a bit about the Health Equity Committee and their role and how they see their role. And I appreciate very much that the conversation that they could end up getting overwhelmed, and also appreciate the conversation that it would be nice someday if we didn't have to have equity carved out in a specific area because we were able to integrate it across the board. But we're not there in our development, and we're still in that both and type of a setting, which I mean, and we'll be there for a while, for a few more years anyway. But I think that the Health Equity Committee is, there's very strong leadership there. There has been strong leadership with our previous chairs as well. And they will not allow themselves to get overwhelmed. They will not allow themselves to be a rubber stamp. And they really want to spread the wealth, if you will, and empower the other committees to be doing the work that those committees need to be doing on equity, on health equity. So I appreciate the conversation, and I think that we need to keep an eye on this tension, if you will, and having conversations among those chairs is going to be critical, as someone has said, as well as the further development of the health equity framework that not only the Health Equity Committee is working on, but that we've also been working on that within the Equity and Inclusion Division for the Oregon Health Authority and for right now for the COVID response. So I think there are some tools and frameworks that will come to bear here. And I also think that we have, once again, very strong leadership in that Health Equity Committee that they will push and force responsibility across the board, so to speak. So that's my addition to the conversation.
Thank you so much, Leanne.
Thank you.
Any other committee members want to chime in before I ask OHA, to Oscar's point about their perspective on this? Okay, so let me just ask, I think Oscar had a specific question. What is the health authority's thought on this sort of, I think, Oscar, I don't want to, it's sort of the more intentional, like the more intentional work around connecting chairs and connecting committee members and is that, I want to be sure, Oscar, is that the question you wanted to pose to the staff?
Yeah, I think I kind of want to get a sense of, you know, sort of like administratively and operationally, how does this work, and how is leadership sort of absorbing a lot of these ideas and recommendations and sort of potential shifts. And I'm sure that they will, and they'll bring it back to us as, you know, as that's sort of the next step. But I'm just curious to hear if there's any immediate reactions like right now.
I'm happy to jump in, but of course would love to hear from others who I know are still on the line. I think this is a good kind of reorientation for us to focus on. There's so many different aspects that we can think about aligning, and I think we've been focusing a lot on aligning processes, which is important. But I think given some of the discussion today, it makes me think that we should be more focused on doing the work to help identify where there are connections across the committees that we know about. And we'll have to get to how do we actually align that work? How do the staff come together to support that? How do the chairs come together, liaisons, all of that I think we can figure out in the future. But I definitely, I think our next step here would be to go back and talk to other staff and say, okay, what do you really have on your charges for the next couple of years? Where would we want to see other committees? Where would you want to see another committee weighing in? Where would you appreciate feedback? Where are your gaps on your committee? That kind of thing.
It's almost like the last slide where it said what the committee needs from the board. It's almost like, what does the committee need from other committees? You know, or what kind of partnership, and see if there's something there. Trilby.
Yeah, so I know Jeremy had to jump off for a legislative meeting, and I guess, you know, in speaking for leadership from HPA, what I would say is this conversation and this sort of imperative is something that I think we're very much aligned with, and it really speaks to efforts that we've been thinking about and working on. So I would say there's an absolute commitment to trying to increase this cross-pollination, especially around these priority issues as you've all been articulating them. And Kirsten, I really appreciate, I think it was you who said, rather than trying to connect them on everything all at once, you know, start somewhere. And we have a nice nucleus of these three issues to start with. So it raises a lot of great thoughts about how to best accomplish it, recognizing that we won't get it all done all at one time because it will be administratively complex. But I'm excited about sitting down with Steph and really thinking about, you know, how could we do this? I again think that nesting concept will help us because we might be able to bucket a few groups of committees, which may cut down on the number of meetings that we'd be considering or asking of people, which is always the thing to avoid. So I think it's a great challenge, and it's a direction we're really well aligned on. And we're definitely going to need Leanne's help to think about how to work in the need for hack and not and be as efficient as possible in how they're looking at what's coming out of the committees.
Yeah, thank you, Trilby. This is Leanne again. I think there's a great, once again, a great strength and a great interest in them controlling the agenda as directed by the Oregon Health Policy Board. So it's going to be really critical that the board be clear and provide that direction as well, so that they are not having to manage too much across committees. But I think I appreciate that the board is talking about this because that leadership will be critical.
Okay, anything else on this topic? This has been really good. I think we have some concrete next steps. Anybody else want to weigh in before we shift to another related discussion here? Okay, I want to come back to a broader question, but before I do that, I did want to make sure, Brenda, that so this idea of nesting, and I didn't want to leave that like that might, I think one of the things you were saying was, might a board member be a liaison to some related number of committees? And that obviously is in tension with managing work. And so I just didn't want to leave that out there. So Brenda threw it out there and then it just was floating out there, and just want to see if any additional thoughts about that. And maybe some of what the sort of context in which you raised that is addressed by some of the cross-sector things we're talking about doing. But I just want to tie that up before we go to sort of the final piece of this conversation.
Diana, thank you for that. And I think you also did a great job of suggesting that our OHA leadership take a look at or listen to what we've talked about today and propose something different for us at our March meeting. And so I feel heard, and thank you for that. Yeah.
Much of the conversation, so this is great. So much of the conversation we've just had is really focused on this cross pollination and intersection. And how many times have I done this with my hands today? I talk with my hands, people. But what I really want to, I want to again take another step back. And are there any other reflections or thoughts you have about how the board, and maybe this is I don't want to say it's the answer, but it's at least one way to get it, sort of how do you manage this work and how do you stay connected to the work, or how do you approach the work? I want to be sure if there are any other issues that you want to lift up based on what you heard from the committees today, that this is an opportunity. And again, there will be more conversation tomorrow, but I really want to be sure if you've written anything down, if anything came up that you thought, oh, we got to talk about this when we're done hearing from everybody. Anything else that board members you want to chime in on about this priority of oversight of these committees? Go, Brenda.
I think just, Steph, I was really struck by your comment about if we as liaisons are doing it very differently, maybe having some additional visibility in terms of the variation would be instructive for us. So just to welcome that feedback. Yeah.
John.
Oh, is primary care in, out, dotted line?
So you mean specifically the Primary Care Payment Reform Collaborative, or is there other?
There's been a primary care committee listed as reporting into OHPB the entire time I've been on the board.
And that, just so I'm 100% clear, is that the Primary Care Payment Reform Collaborative? Yes, okay. Trilby, you look like you have.
Oh, well, I guess the thought I had was that when we heard from Chris, what she said is the reason for the dotted line is that it is technically not a committee, it is a collaborative. And so it has a slightly different status. And for that reason, John doesn't have chairs and may see its role in terms of reporting up to the board slightly differently. It is an area for which the board has a statutory responsibility. So I think that the relationship there is that the board has an interest and that the committee wants to be heard to the board. So it's definitely included in what we think of as work that the board should stay apprised of. But it's a slightly different relationship in terms of being a formal committee of the board. Does that make sense?
Yeah, I mean, the question I would pose to you all, and I've done a little bit of this. When I went to Jack Friedman and asked Jack, now Jack, who are going to be the foot soldiers that are going to get 889 done? And he said, oh, primary care. Really? Okay. Who are going to be the foot soldiers of this transformation? Because whoever the foot soldiers are, we better be talking to them. We're recruiting them through the workforce because I define primary care writ large. It's not just a bunch of doctors. It's nurse practitioners, it's community workers, it's a broad group of people. But, you know, if we're really serious about equity and all of these issues, eventually it has to get down to a subset of foot soldiers who do it. And it doesn't have to be primary care. It can be somebody else, but I think it's important, and then we don't have to decide this today, but who is that? Who's going to get this done? You know, I would point out when the VA was at a near-death decision point in the 90s, one of the things they decided was our foot soldiers are primary care doctors. And they created an incredible primary care system. They struggled, you know, with specialists a lot. But that was a key decision to their transformation. You know, they were one of the first to invest in information systems and electronic health records, and they really went with primary care. I'm not sure OHPB needs to do primary care, but if they're who the transformation is going to go through, somebody better be focused on them and advocating for them. But, you know, I'm a retired primary care doctor.
Well, I think, John, that's something you can look for in what we come back to you. You know, do you see it there? I think, you know, if that were grouped with the cost care growth target, if I said that right, healthcare cost growth target, then you would begin to see that interaction between primary care, VBP, and total cost of care, and how all those recommendations are coming together. I think that's part of what you're wanting to see, and you're wanting to see that voice of the primary care groups in those recommendations, and that should be happening. And to help the board be assured that it's happening, we could do some of that grouping.
Yeah, you know, I would remind us, if you look at all the measures that we work with, there are a few dental measures that are terrific and great work being done on those, a few mental health measures, but most of the measures are primary care.
Yeah.
There's no specialty measures, and there's no hospital measures. So kind of passively, we've said it's going to be primary care.
And just to this point too, that I think the last slide on Krista Mars's presentation in terms of the future work specifically called out, how does the collaborative, the primary care payment reform collaborative, how does that group intersect with, leverage, work with the work coming out of 889? So I think, I mean, Chris, I don't know if you want to speak to that at all, but I know that was on your slide, and I think this is part of what both Trilby and John are speaking to. And then David, I saw you want to say something, so I'll come to you next. Chris, you're on mute.
I just saw that. I don't think I have anything substantive to add except just reiterating that workforce committee as well, and then even health equity committee, maybe given the traditional health worker and PCPCH standards, equity related work. So yeah, really appreciate the conversation. Thanks.
David, go ahead.
Well, John, as a former primary care physician myself, you know, I think primary care has an important role to play in addressing inequities in the healthcare delivery system, but health equity is baked in long before anyone ever touches the healthcare system. And I think it's baked in through housing policy and income opportunity and immigration status and so many other things. And, you know, I think these equity discussions, well, primary care has an important role to play, again, moves way upstream for us to really, because that's really where the levers exist to make a true and effective change.
Okay. Any other big issues on, any other issues that surfaced for you when you were hearing from the committees? Please, Kirsten.
kind of ties into what Chair Beansberg was just saying. One thing that occurred to me was that kind of how do we as a board with the help of OHSA staff kind of identify these in-between spaces and problems so that, like, I think about the work of the cost growth target committee and thinking about unidentified or unintended consequences and maybe challenges that, I don't know, structural challenges not to our organization, but to the industry, or just like there's this hole and we're not going to meet our health equity goal because of X, and it's no one committee's charge. But so how do we identify those major roadblocks, and then how are those coming before the board, either in kind of those potential annual hearings where we're thinking about the structure of the industry, or I don't know, and those roadblocks could be big things that aren't OHA's responsibility or our responsibility, but that, like, we as a health policy board are like, we need to give voice to food deserts, or you know, income inequality, and it's not our charge, but we're going to send a letter in support of this piece of legislation that is doing it or something. I think there's that space in between where, like, if we want to move towards health equity, we have to figure out how we give voice to say this is important to health. And we as Oregon Health Policy Board think we should support that in the same way that, like, we joined on to the, like, racism is a public health crisis, right? And so, like, but that came, you know, that came to us and was great. How do we invite more things like that to come to us, to say that, like, we want to be supportive of upstream efforts, even though it's not our charge? Or I take that back. It is our charge, but not in our portfolio of daily work.
But Kirsten, you said it so well. It is in our portfolio. I mean, I think it really is squarely in our portfolio, because the governor is one of the 3 areas the governor's asked us to concentrate on.
Please, John.
You know, as I listen, I mean, you all basically were saying who's able to take money and power from spot A and move it to spot B, move it upstream. And David, you know, I'd say, I totally agree with you, but somebody's got to be able to take it from A to B. Now, frankly, I think CCO 2.0 did some of that. Thank you, Patrick. You guys did that. You know, thank you, Brenda. I mean, CCOs have done that. So do we want to really try to help do that in other ways? It means we have to figure out somebody who's got the money and power and get them to give it to somebody else.
And I think part of that is we've been hearing, like, what are the incentives? How do you change the incentives and sort of shift the culture as well, right? And that is, and I saw Kirsten saying, lip syncing, that's hard, that's so hard, but also nodding her head vigorously that has to, you know, that's part of the work. Go ahead, Trilby. You're on mute. There you go.
So hard, this muting and unmuting all the time. I just wanted to add that we do need to stay cognizant of the levers that we have, you know, and you as a board at OHA, you know, what are the most important levers that you can pull, the things that you can really work with to make a difference. And we are forced to prioritize because we're all very busy people and there's only so much time that we have to work together. So again, it's the sense of, you know, not taking on every potential arena in which we could be speaking to equity, but trying to be strategic about where we focus. which is so hard and so exhausting. But I think it's our responsibility to do that on an ongoing basis as well. Sorry to be a Debbie Downer here.
No, Brenda, go ahead.
I'll be your counterbalance, Trilby. You know, I love that you remind us of reality, and I think that it is this board's responsibility to continue the pressure around healthcare transformation, right? So we're thinking about it in a context, and as Kirsten pointed out for us, people are bringing things to us to basically ratify, but what is it that's ours to do? If we've got committees that are asking us really honestly for that definition, isn't it incumbent on us to respond? You know, and take that leadership space. When I looked at the catalog of OHPB and how many times we've been in leader roles, when we're collaborating, when we're just sort of holding space for really critical conversation to move forward, each one of those roles are so important. But what a better time than in a retreat to talk about what is our charge in the transformational space itself, and what's getting in the way of us actually leaning in and stepping into places where we think that we're uniquely positioned to do some heavy lifting.
Right, oops, I keep raising my hand. I completely agree with what you're saying, Brenda. Those places where we're uniquely positioned and leading in those positions, those places.
David.
Although we may have more, better developed levers in the healthcare delivery system, you know, we can also use the healthcare delivery system as a bully pulpit, as a point of focus and conversation to look at less well-developed levers upstream. You know, while we can't make a CCO accountable for making sure everybody is housed in their system, solving the housing crisis, we can use the CCO and other healthcare delivery partners as champions to advocate for fair and affordable access to housing. And that's a less well-developed lever, but I think a really important lever for us to define and figure out how to use the healthcare delivery system as advocates to make that happen. And that's how I think that's how we move upstream, is by finding new opportunities for change that haven't been as well developed as how do you deliver value-based care, how do you deliver you know, well-defined traditional healthcare delivery. And that's what we did with social determinants of health. And that's, you know, that's part of that, using the healthcare system as advocacy to say, we need to pay attention to this in addition, and maybe even you know, this has equal, if not more importance than traditional metrics of healthcare delivery.
As we wrap it up, just in our last few minutes, I want to actually, both things that folks have said in the last 5 or 10 minutes, I think really, you know, Brenda, you use this, you know, what is the board uniquely positioned to do, and what is our charge in this sort of transformational space? And I think, you know, earlier Kirsten talked about like, this is the place, and this is, we heard it from Jeremiah and others, like this, that one of your priorities is this committee oversight work, and it's the priority of knitting it all together and having that overall view. And it's a big job and it's a hard job, but sort of what we've been talking about is how do you best use your committees, and what are, you know, both the what are some of the mechanisms that make that job more doable and doable well. And so some of this cross sections, you know, talking across committees and lifting some of that up. And, you know, Kristen talked about finding the gaps, and where, you know, where are those spaces where your unique perspective allows you to not only identify them, but lift them up and make recommendations about doing something about them. And then to, I think, David's last point about what are those, you know, as you're focusing on 889 and the waiver renewal and equity, how do you use those opportunities, just as you use CCO 2.0, to David's point, to sort of to lift up some of those other issues that may not be as well explored or, you know, set in stone, so that there is opportunity to do that through these focus areas. Before I just sort of wrap it up, I want to see if any final comments, and then I'll leave it to David and see if Oscar or David has anything to sort of close us out. But any final comments? Final comments, and then I'm going to foreshadow tomorrow. So final comments, and then I'll go to David and Oscar. But anything else from any other board members? So tomorrow, I mean, y'all did a lot of listening today, although this last discussion, I hope you found sort of to be the kind of robust discussion that you all want and should be having with each other. There's going to be much more of that tomorrow. So really, the schedule for tomorrow is really focused on the priorities and how what are the ways the board wants to, we have some proposals for you, but what are some of the ways that the board can be leading, collaborating, supporting, communicating, as you know, in those areas. So we'll be focused, we'll do a little level setting on priorities, but then focused on cost growth target, waiver renewal, health equity. And then we will have this discussion that's come up a couple of times today about what about past priorities? What happens with some of that work out there, whether it's children's health or behavioral health, and want to have a discussion, you to have a discussion with each other about that. So that's where we're going tomorrow. And I appreciate everybody sticking with it. It's a long time to be on a Zoom meeting. Really want to acknowledge the work of the committees and the chairs and the staff and the health policy board staff, because pulling that all this together is a ton of work. So really want to acknowledge all of those folks. And with that, I'm going to turn it over to David and Oscar to see if either of you have closing comments.
Oscar?
Just thank you all for your attention and all your work towards this health equity. Thank you.
Diana, great job facilitating the discussion. I want to thank OHA for bringing these committees together, all committees. So, and all of your great work to see sort of the synergies between and amongst these committees and the work the great challenges we have ahead of us. And I love working with y'all.
Thanks, everybody. We'll see you tomorrow.
Thank you.